A very good morning to all of you. I'm Dr. Priya Nagraj, the CEO of Pune Knowledge Cluster, or PKC. And PKC, in collaboration with the Office of the Principal Scientific Advisor to the Government of India, or the PSA, is happy to host today's G20 Chief Science Advisors Roundtable side event on One Health, disease surveillance, and pandemic preparedness. I express my deep gratitude to our esteemed speakers, panelists, dignitaries from the government, members of the press, our partners and stakeholders, and all of you in the audience for agreeing to come together to participate in today's discussions. The Pune Knowledge Cluster is a 3-year-old organization established by the Office of the PSA to promote active collaborations between academia, research, industry, and the government, and leverage these collaborations to foster initiatives that can lead to the betterment of cities, states, and the country. PKC is one amongst 6 clusters in the country, and we work in the areas of health, sustainability and environment, mobility, big data and artificial intelligence, and capacity building. We strongly believe in the strength and potential of collaborative approaches to solving problems at scale, and work with over 50 partner organizations to conceptualize and implement programs that are evidence-based and data-driven. A great example of this is the work that we've been doing over the past 2 years in disease surveillance. We've been working with over 20 highly reputed partner organizations, including hospitals, R&D labs, startups, industries, and our local civic bodies to build a strong foundation for public health surveillance in the city of Pune. This includes helping developing of protocols for clinical and environmental surveillance for infectious diseases, enabling development of rapid diagnostics for detection, and capacity building for research labs and civic bodies. As a cluster, we are strategically placed to foster interdisciplinary interactions, which is necessary for achieving integrated and sustained outcomes. We hope to build on our work through these discussions in today's meeting. This meeting is aimed at bringing together all relevant stakeholders interested in contributing to this cause and encourage sharing of views, perspectives on what it would take to create scalable public health surveillance systems. I'm glad to say that our speakers and panelists are joining us today from different parts of the country and the world. Some will join us virtually as they couldn't travel to be here today. We will begin with a short video recorded welcome address by Dr. Parvinder Maini, Scientific Secretary, Office of the PSA. But before we begin, I would like to make a few administrative announcements. First, we have some great posters displayed in the adjacent room, which I request you to take some time and visit during your break. We will also take a group photograph in the terrace adjoining this room when we break for tea. We will also be streaming this event live on YouTube, and I request the team to display the link for joining this online. If this room gets filled up, an adjoining room is ready where this event will be relayed live, so you will be able to watch this event comfortably from that room. And lastly, I request all of you to keep your mobile phones on silent. I thank you once again for taking the time to be here and hope you enjoy this event. Thank you. Can we have Dr. Maini's video message, please?
My warm greetings to one and all. I am very pleased to address this distinguished gathering. My apologies for not being there in person because of other official commitments. The chief scientific advisors are embedded into the highest level of governance and play a critical role in shaping policy choices by providing evidence-driven science advice with the goal that the science and technology can benefit all. With global challenges such as climate change, cybersecurity, increased digitalization, the importance of science advice for policy making is increasingly being felt. And for this, it is important that we have a global view of the science advice mechanism for the global good. In view of this, the G20 Chief Science Advisors Roundtable, which we call as G20 CSAR, a flagship initiative which has been introduced during India's G20 presidency and is being led by the Office of the Principal Scientific Advisor to the Government of India. The first meeting of the G20 CSAR was held in Uttarakhand, in Ramnagar, in March 2023, where we converged on 4 topics as follows. The first one was the opportunities in One Health for better disease control and pandemic preparedness. The second, synergizing global efforts to expand access to scholarly scientific knowledge. The third, diversity, equity, inclusion, and accessibility in science and technology. And the last, an institutional mechanism for inclusive, continuous, and action-oriented global science advice. Under the theme Opportunities in One Health, which is the topic of today's discussion, we discussed pandemic preparedness, plan for a flexible, adaptive, and timely response to pandemics, integrated disease surveillance mechanisms for humans, livestock, and wildlife, R&D roadmap for disease of One Health, and investing in analytics such as disease modeling, AI/ML tools, and data standards. The next G20 CSR Roundtable is planned in Gujarat in August 2023. As a run-up to the second G20 CSR meeting, the Science and Technology clusters established by the Office of the Principal Scientific Advisor to Government of India is organizing a series of high-profile side events around these various themes. Today's event is one amongst them. Insights emerging from these side events will enable effective discussions during the upcoming G20 CSAR meeting. S&T clusters were established to create strong linkages between existing academic institutions, national and state laboratories, and other stakeholders like relevant ministries, industrial partners, startups, MSMEs, state governments, philanthropic foundations, and international organizations. Over these years, these clusters have played a critical role in promoting dialogues to foster and enable collaborative R&D and decision-making in various areas of science and technology. Over the past 3 years, the Pune Knowledge Cluster has actively built and managed a consortium of reputed organizations who have come together to create a robust disease surveillance systems for the city. These efforts began with COVID-19 and are now being extended to vector-borne diseases and AMR. It is essential that these efforts are sustained and integrated with the city and state surveillance systems. This should involve active interaction with city officials at early stages to ensure that systems being built are relevant and practical in terms of outputs. It is indeed a pleasure to see such diverse participation in today's discussion on One Health, disease surveillance, and pandemic preparedness. The fact that this meeting is being attended by senior government officials, public health experts, reputed scientists, and policymakers goes on to show the serious commitment from various stakeholders to collaboratively build integrated disease surveillance systems. I really look forward to the outcomes of today's meeting. Today's deliberations will definitely help us in adding value to the discussions during the second roundtable being organized in Gujarat. I wish this discussions great success. Thank you.
We thank Dr. Madan for her address and also setting a context for this meeting. I would now like to invite Professor Shashidhara, co-founder director of Pune Knowledge Cluster and the director of TIFR and CBS Bangalore, to share his opening remarks.
So very good morning to all of you. Thank you very much for coming on this day, or for people who have, many of you have come from all over the city and some of you have come from outside the city too. My colleagues, Dr. Rakesh Mishra and I think Surabhi, they're all here who have come from outside, and Rohit and few others. And I just let it make it very informal. Pune Knowledge Cluster was conceived all knowledge cluster were conceived by the principal scientific advisor to Government of India in 2017-18. At that time, Vijay Raghavan was the PSA. And along with Vice Chairman of Niti Aayog, they thought it's a time that we should build consortia in each city where the, the, the people with diverse expertise and resources will come together to provide science-based and data-driven, evidence-based solutions to the real-life problems of any city. Particularly in Indian context, compared to other countries, the urbanization has been extremely rapid in the last 30 years. And almost all cities, the urbanization is sort of characterized by three major problems or four major problems. One is extreme mobility because of the population density and the opportunities in urban space is providing to people. And inequity is expanding. And then the pollution. And amongst these one, if we further divide, the problem would be one is public health. Because of the poor hygiene and extreme mobility, infection would spread like wildfire whenever there is an outbreak. Second is, because of the pollution, public health problems will get aggravated. And the third is the water management, both in terms of the quality of the water and the access to the quantity of water, equitable water distribution. In the context of environment, in addition to the pollution problem, any of this urbanization will also lead to degradation of natural habitats, particularly the peripheral areas of the city, both within and the peripheral. That will add to the problem. So when you address some of these kind of problems, while cities are still expanding, one has to really think ahead and use all kinds of scientific methods to address these problems. So when we were invited to participate in the discussions and also to create Pune Knowledge Cluster as a platform, one of the major verticals we proposed was public health, and see how all the organizations, the government organizations, all the hospitals, and the NGOs and the industry together, and can address a problem whenever there is an outbreak of an epidemic or pandemic. In fact, it's somewhat coincidental, obviously, for all of us, that 2019, in the beginning of 2019, when we proposed Pune Knowledge Cluster as a entity that we want to establish, the proposal had 2 pages of write-up on pandemic preparedness, without knowing anything that within less than a year, you would be facing one such, disastrous, natural, occurrence of a pandemic. Nevertheless, one thing that happened was, because there was thinking about knowledge clusters and how to pool resources, and deployed, manufactured and deployed across the world is also indication that is very important, that international cooperation is the only way we address any such disease problem. And the increased mobility across the globe and the sort of the patchy access to resources in different parts of the world it's some of the things we have to be very conscious when dealing these kind of problems. Again, taking the example from the current pandemic, thankfully not the current one, the recent one, I should say. Dr. Soumya Swaminathan is here from former chief scientific advisor to WHO. Would talk a little bit more about it. We didn't have DNTPs in this country to make RT-PCR kits in April 2020. We didn't have any reagents. Most of the reagents required to make RT-PCR kits were imported, and because of the lockdown, most of these things were sort of unavailable. Is because there was no movement of these kind of resources, and also there is a big demand all over the world. Even developed countries which had access to production of DNTPs or enzymes, they stopped supplying to other countries because their own demand was increasing. So many of the scientists, technocrats, industry people, they came together and started making all these reagents in-house. And within a year or so, India could start producing completely indigenous RT-PCR kits to an extent that almost a million kits per year were produced by this kind of a consortium. Some of you in the audience are involved in developing these kits. I see Nikhil is here from GenePath. He was also a part of this consortium. So I guess, as you could see here, it has to be collective. And thankfully also, we had financial resources coming from diverse sources. For example, Persistent Foundation in Pune supported this entire Sero survey, the first of its kind that we did in India. And later, Rockefeller Foundation, Hindustan Unilever, Leela Poonawalla Foundation, and Bajaj, and then several other foundations that provided financial resources to provide science-based, evidence-based, and a data-driven solution to the problem in this particular region. So given this experience, it's very important that we go forward with similar kind of approach. But typically, the preparedness is always a question mark about how serious one would be when you're preparing for something which is unknown, something which is not predictable in terms of timeline, and how serious it would also be an issue. The day a new outbreak may happen, it may be considered as very serious, but it may die down within no time because the nature of the pathogen itself and in its evolutionary history. So given this, how seriously one can put together a good mechanism, a robust mechanism of preparedness is something very important. And thankfully, there are multiple non-human technology-driven approaches are possible. How you collect data, how you process the data, how you sort of come out with certain projections that can be made with less intervention with human brain. So that makes perhaps more robust is simply because, a machine may not be thinking less seriously or more seriously simply because, it may not be a real life problem. But all robust preparedness plans should be in place with international cooperation. That's why in this context, G20 side event that is given an opportunity by PSA's office to us is very important. Given that Pune had faced many such epidemic outbreaks and also suffered because of the pandemic, it also has all kinds of resources. NIV is based here, NARI is based here, and IISER is based here, BJMC, and YCM. And also the public health officials are extremely cooperative in this city. All the commissioner's office, they're always been forthcoming to seek scientific and data-driven approaches to address the problem. So I think the Pune city hopefully will set the role model for the whole country and perhaps for the whole region. Thank you very much.
Thank you, Shashi. We just got a message from Dr. Swaminathan that she has to leave for another meeting soon. So my apologies, Dr. Monday. If it's okay with you, I will ask her to speak first. Thank you. Dr. Swaminathan, can you unmute yourself and maybe switch your video on? I would like to formally invite Dr. Soumya Swaminathan, Chairwoman, MSSRF, and former Chief Scientist, WHO, to share her views.
Good morning, everyone. I hope you can hear me all right. Thank you so much for this opportunity. And apologies, I had actually put it on mute, thinking there is still some time to go. So thank you for accommodating me also early. I think this issue of pandemic preparedness, One Health, and surveillance is obviously very important and topical, considering that we have just come out of a pandemic, which had a huge impact all over the world, including in India. And it is important to also look back and analyze some of the strengths, weaknesses, challenges, and opportunities that are present in the ecosystem, so that we are able to actually make a plan for further strengthening of the ecosystem. Now, clearly, what is needed firstly to deal with these type of emerging threats, and I would say that we have to be cognizant of the fact that we have a lot of existing, or what we may call endemic pathogens, which we cannot ignore. So we cannot put all our effort into detection of new pathogens while we ignore the ones that are currently causing a lot of mortality and morbidity. On the other hand, in fact, if our systems are able to deal with the existing threats, infectious disease threats that we have, understand the epidemiology, understand the risk factors, understand how these infections actually are getting transmitted and playing out. So there's still a lot that we don't understand about existing endemic, so-called endemic infections. And if we can develop the system to actually address those threats, then I think we are in a state of readiness and preparedness for a new threat that could emerge. So I think our surveillance systems, as we know, in a way, are not yet where they should be. So I think the first set of gaps would be really to try to look at the surveillance that we have, disease surveillance in humans, in animals, and in the environment, and see how they can be made more integrated. There's more collaboration, more synergies between these systems, more data exchange and data use and analytics, which actually make sense of these different systems. A good example here could be antimicrobial resistance, which is clearly an absolute existing threat It's a growing threat, and we know that there is data that exists on antimicrobial resistance. The ICMR runs a hospital surveillance system for antimicrobial resistance, tracking priority pathogens, mainly bacteria and fungi. And we have trends from a couple of dozen hospitals around the country, but those are mostly tertiary hospitals. We also have a system of surveillance in the animal and veterinary sector. And then we have perhaps less well developed, but we do have some amount of environmental surveillance for antimicrobial resistance in water and wastewater, some kinds of sentinel surveillance. But again, it's not as well developed, and perhaps a lot of it has been done in research mode. So I would say that the challenge is really to think about an integrated system of antimicrobial resistance surveillance for at least a set of priority pathogens, which is then used to inform actions and inform policies related to prevention and management of this threat. So that's one example. There could be other examples also. We do have outbreaks of waterborne diseases periodically, from time to time, still causing deaths. It's often not very clear that these outbreaks are cholera or other waterborne infections. So I think doing those investigations very rapidly, arriving at the conclusion, and then having that discussion, particularly with the local officials at the district level, would help, I think, to put in place systems to prevent future outbreaks. So that's, I think, around surveillance, a whole set of activities, and I'm sure there'll be other speakers who will address this today. One of the big challenges, of course, not only in India, but globally, is the siloing of data, and attempts to bring together, I think, should be really a key focus of this activity. A second area I would say is really, of course, in the countermeasures development, preparedness to develop that, the R&D side, the innovation side, as well as how these will be deployed. And here we saw that India did really well during the pandemic because of our capabilities in R&D, the startup ecosystem, the number of entrepreneurs we have, innovators, but also industry that's willing to take on these big challenges and respond. And therefore, I think there needs to be, again, an R&D blueprint or roadmap for the country, which is based on the disease burden that we have, and side by side building the systems and building the prototypes for response to a new pathogen or an unknown pathogen, or when you need a modification of existing countermeasures, whether these are diagnostics, vaccines, or the development of drugs. There have been lots of meetings, I think, consultations that have been held over the last few months, really, and I think it's a matter of time before a comprehensive blueprint could be developed with a clear roadmap, a research roadmap that is developed for each of the priority pathogens. This is something that the WHO has done at the global level, but I think for a country like India, again, it is worth doing this exercise. And as I said before, focusing on existing pathogens, like, let's say, Mycobacterium tuberculosis or dengue or chikungunya, and using that as a case to prepare the whole system, actually to deliver a product in a defined period of time, which is what you need when there is emergence of a new pathogen, I think would also be very, very helpful. The third area would be really around clinical management and clinical services. And this, I think, would fit very well with the expansion and the investments that are going into the Ayushman Bharat program. There's the PM Abhim program that is developing infrastructure. Side by side, hopefully, there will also be a strengthening of human resources, because we know that having infrastructure, buildings, equipments will not perform unless you also have the trained manpower. And by trained manpower, it's not only doctors and nurses, but it's really a team that is needed in order to deliver good primary healthcare services. And primary healthcare really is the foundation not only for universal health coverage, but for pandemic preparedness. So ultimately, it all boils down to the services that are available at the periphery, the first point of contact, because epidemics, outbreaks, whatever it is, which ultimately becomes a pandemic, it begins and it ends in communities. There's always a first case, and that first case is always in a community. So unless we have good primary healthcare system, which has already built that engagement with the community, which has already earned the trust of the community, where community health workers are trained to report cases that arise. I think the case of anthrax in Koraput district of Orissa is a good case study to understand why those cases could not be reported to the public health system before several people had died, despite the fact that animals were sick, human beings were sick, and several people actually lost their lives because of the delays in reporting. So I think learning from such experiences and strengthening the links between health system and the community, and also making sure that when people get sick, they can get emergency services, whether it is oxygen or whether it is other essential health products. So there's a wonderful opportunity now to build, that into the into a resilient health system. We also have to now recognize that climate change and climate shocks are going to be more and more common. And therefore, as we are building up our health system, we need to build also climate resilient health systems with things like solarization of health facilities, making sure that in areas which are prone to flooding, the health facilities are located in places which are not going to be flooded, and that there is thought given to how to manage an emergency if it occurs. So local planning, again, will be important, as assigning of responsibilities, an SOP, an action plan to respond to those emergencies. I think the fourth area is around the use of data, both for development of policy and action, but also for communicating to the public, transparent, frequent communication in a way and in language that the public understands, to inform them of what's going on. Because especially when there is an emergency, whether it's a natural disaster, whether it's a biological threat, there will be a lot of panic. And so that needs to be addressed really through communication. But also, as I mentioned earlier, the development of a strong engagement, community engagement through the public health system serves an excellent, we saw even during the vaccination program, that it was building up that trust, and the fact that leaders, local leaders, whether they were government officials or whether they were trusted leaders of the community, they played an important role actually in building up that confidence. And India was one of the countries which had very little refusal to accept the vaccines. And we had, as a result, a high vaccine coverage. But there was a lot of effort put in, particularly in places where there was an initial hesitation. So that is important. And then the fifth component really is the coordination and the leadership and the governance of this whole system. There needs to be, again, a well thought through, but also well publicized mechanism for the coordination of all of this at the national level, state level, district and sub-district level. And ultimately, the officials at the local level, which is a sub-district level, will need to be empowered, because again, things begin and end in communities, begin and end at that level. And if we really wait for somebody at the state or central level to take action, it's going to be too late. So the goal ultimately is that, we're not going to be able to prevent in each and every infectious disease outbreak from occurring, but the goal would be to detect and act, respond as quickly as possible. Of course, prevent wherever possible. So prevention is again through water, through vectors, really understanding how these different pathogens are spreading and taking action to prevent as far as possible. But ultimately, one will need to detect and respond early in order to prevent an outbreak from becoming an epidemic, or epidemic from becoming a pandemic. I think so that should be the goal. And having sort of mock runs and drills to really train officials and the community at the lowest levels ultimately will, I think, give us. So coordination at the center of it. And then you have the R&D, innovation and preparedness, the surveillance, which has to be a collaborative surveillance, the clinical care pathways, and the community engagement, and then communication on these issues to the general public. So I would stop there, and I'm happy to take any comments or questions if there are. Thank you.
Thank you, Dr. Swaminathan. I know you have a hard stop in 5 minutes, but we would like to open the floor to a few questions. If anybody has a question, please raise your hand. We have a mic here for you to ask your question. Please introduce yourself and then ask your question, please.
Ma'am, I am Dr. Uma Isola, and I work with Access Health International. We're a think tank advisory and work closely in the area of health system strengthening. My question to you is, you have seen the global scale of what it did and how it put us back by so many years. How do you think we are going to look at it as we go forward, as much as we are likely to prepare for better? What is the reality, and how do you think the globe will take forward something? Because this is one that will happen, and maybe another we don't know anything about.
Right. Absolutely. I think we can't predict when the next pandemic will happen, but you're right that it's going to happen. And of course, side by side, we know that there are negotiations going on at the global level. So there are negotiations at the WHO through the intergovernmental negotiating body that was set up in 2021 that is looking at this development of a pandemic treaty, which is to address some of the issues that we saw during the COVID pandemic, mainly around the inequitable access to diagnostics, drugs, and vaccines. So, also the disproportionate impact the pandemic had on poor people as well as in poor countries. We know that it's going to take decades for the low-income countries to recover from the economic shocks of the pandemic, whereas the high-income and upper-middle-income countries are recovering much quicker. So, yeah, there have been long-term impacts. And therefore, to address that and make sure that this doesn't happen again, the pandemic treaty has equity at the very heart of the negotiations and equitable access to products. Now, this is, of course, a very difficult. We saw during the pandemic how the world really could not come together and act in solidarity. While science actually did provide the solutions, the solidarity part of it was missing. Now, whether this will be rectified and whether the next time around we will have more equitable response, I don't know. I think time will tell, and it will really depend on countries putting the global well-being at prioritized over and above the well-being of individuals within national boundaries. It's a very difficult thing to ask for. And similarly, I was looking at the text for the political leaders who will meet in September at the UN at the high-level political forum to discuss pandemic preparedness. The text right now is rather weak. It really doesn't make any big commitments, and it has just says that yes, we should do this and that if appropriate, if applicable. So there are a lot of ifs and buts, and so I think it's at the political level that these things can be negotiated. But having said that, I mean, I think we are also thinking about at a country level. India is such a large country and has such an impact globally as well. Our products, did go all over the world. Therefore, I think through the G20 mechanism, we could actually make significant steps towards building the capacity for R&D, building capacity for manufacturing in areas of the world which are right now underserved. I think India can play a leadership role there in really supporting the development. I was involved in setting up the mRNA technology transfer program at the WHO. The idea was really to democratize the availability and access to new technologies, which should not remain in the hands of a few large companies, but which should be made available to academics and to manufacturers all over the world. Of course, governments need to invest in that. and cannot depend only on donations, but the know-how and the technology. Certainly, I think India can play a role in disseminating it and in getting the G20 actually to work together to make that a reality. So I think on the one hand, yes, there will be high-level political discussions, commitments, but in a very practical way, I think we can do a lot to develop technology. I think genomic surveillance is one area that has grown by leaps and bounds, in the last couple of years, because of investments made by countries that can be really leveraged today to expand genomic surveillance in a way in which it suits us, But at the same time, I think this global data sharing platforms, all of that has opened up a lot of opportunities for open data and open science.
Thank you, Dr. Swaminathan. I would now like to invite Dr. Shekhar Mande, Distinguished Professor, Bioinformatics Center, Pune University, and former Director General, CSIR, to share his views.
Thank you, Priya. Both Shashi and I, being the board members of PKCF, I think it becomes our duty to welcome all of you very warmly to this half-a-day meeting is organized by the Office of the PSA. Now, I understand that PSA's office has organized this as a part of the G20 group to make a statement on One Health and pandemic preparedness. It so happens that there are other verticals of G20 that are taking place at this moment. And I'm a part of the core member of an engagement group called S20. S20 is the Science 20 with both PSA and I. We are the members of the core group, and it is co-chaired by Dr. Vijay Bhatkar and Professor Ashutosh Sharma. Now, S20 is an engagement group. It has an advantage that we don't involve the government directly in the deliberations. So all the science secretaries of the government or any secretary of the government or the ministers or the chief ministers and the governors, they necessarily stay away from the deliberations. So that's an advantage of the S20 engagement group. And the three themes that we had chosen to discuss in the ambit of G20 in the S20, where the first one was energy and energy transition. That happened in the first week of April in Agartala. The second meeting that what we had was in Lakshadweep in the first week of May. And that had actually something topic, what we are discussing today is on universal health and wellness. So the universal healthcare and wellness is kind of semantic, is something very similar to One Health, and I'll come to that a little later. And the third meeting that what we had was on science, society, and culture a few days ago in Bhopal. And the S20 engagement group is now preparing the final paper that will be presented in about 15 days from now. The S20 members, or the G20 members who participate in S20 are the different learned academies from different countries in that. And from India, essentially is the Indian National Science Academy, which participates and makes a formal policy statement, which would be presented to the G20 core group later. And as One Health was part of it, or rather what we called as universal health and wellness was a part of it, the deliberations were very similar on the lines that what we are having today. One of the things that actually came up there before I come to pandemic preparedness and all was a very interesting topic, and that concerned with social culture and practices. I mean, in many countries around the world, which have very long tradition or history, the preparedness for diseases is somewhat inbuilt. Not that there not have been pandemics, not that there not have been very large number of deaths at any point of time in these cultures and all, but nonetheless, the societies had accepted particular kind of culture in which any kind of diseases actually were dealt with at the societal level by following certain kind of social practices. And the same issue was also drilled upon in Bhopal meeting when we actually connect science with society. Now, this particular issue, how science connects with society, has long been deliberated by different kinds of people around the world. In 1920s, J.D. Bernal had articulated extremely well the social functions of science. But what is the recognized phenomena is that the lab level science that what many of us are used to doing is purely advancement of knowledge and publishing that and have it peer reviewed. That eventually finds its way into technologies. until it becomes a social practice. I mean, over a period of several thousand years, we have seen that many scientific advances that were made, they eventually converted themselves into technology which could be practiced by common people and eventually became a part of our culture. I mean, there are many examples, and today is not a forum where we dwell upon this particular one, but has a very important role once again for pandemic preparedness, that how these practices have actually led to our issue of pandemic preparedness. Now, there are also learnings from the recent pandemic. Both Soumya and Shashi talked about what we actually did. And what I would like to do is to bring a perspective from the government, where I was involved during the pandemic period, and how government was dealing with this, and especially how CSAR, where I was, dealt with the entire issue of pandemic preparedness. Now, CSAR's pandemic preparedness, I mean, our team, we had put in place even before the first lockdown was announced. In fact, WHO declared COVID-19 as a global pandemic on 11th March 2020. About 15 days prior to that, on 25th and 26th February 2020, CSAR had already had a meeting of all the directors where we had discussed the potential of this particular disease becoming a pandemic. So about 15 days ahead of WHO, we had started our deliberations that if this becomes pandemic, how are we actually going to deal with it? And even before the first lockdown, which was announced in the country, that's around 23rd March, we had actually defined 5 verticals in which we are going to deal with the pandemic. And we put in place a mechanism by which what we called as a strategic group, which met every evening at 6 o'clock online. Rakesh Mishra was part of that. And we met something of the next 6 months every evening, even on weekends and festivals and so on and so forth. And what we had actually put in place are the mechanisms, which some of it actually I will very quickly share with you. I don't have too much time to talk about, but certain mechanisms in place. For example, surveillance has been talked about. And we thought that there had to be 4 different kinds of surveillance mechanisms in place. The first surveillance, Shashi briefly mentioned about zero survey. We put in place zero survey for a cohort across the country, and the cohort was all the CSAR employees. So that gave us a very dedicated sample where people would come in a longitudinal way as the disease was actually progressing. And this was done 3 times during the entire pandemic time. And therefore, we could actually gauge how the virus was sweeping through the society. And the papers have been published. There's some fantastic papers have been published, one of them in Science, one of them in eLife, and so on and so forth, on the zero survey that CSIR had done at that particular point of time. That's one aspect. The second aspect, Soumya also mentioned about genomic surveillance. And very early, just as government was actually discussing how do we actually put in place the mechanisms to deal with the thing, CSIR actually began doing genome sequencing. So we are among the first, we are rather the first organization that actually started very large-scale genome sequencing of the samples that were coming. And in fact, Maharashtra State, I must compliment Dr. Karikarte here, put in place a very strong genomic surveillance mechanism. And Kerala had done that, and the similar parts of the country, other countries, we did that extremely strongly. So we have sequenced several lakh viruses out of this, and they were being deposited with NCDC. Now, both these aspects, the zero survey and genomic surveillance, they deal with the pathogen directly or the human subjects. What one needs to actually also do is a complementary surveillance on the environmental factors, right? And that's what actually I meant social practices and all that our culture has that. So the environmental factors here could be many, but in this case, it was essentially air. And once again, we are very proud to say that much before the world recognized that the virus is airborne, including CDC and other major organizations, CSAR study, which was led by Rakesh Mishra here, they recognized that the virus is airborne. And they actually published this beautiful paper in which they have sampled air from multiple different places, whether it be vegetable markets, in the hospitals, in the patient hold area, in the OPDs, in the ICUs, in the houses where there are actually people who are affected, the house where the patient is actually housed in a room, or in the kitchen, or in the living room, or in the toilet. And it's a beautiful study actually that has been done to show that how virus actually spreads through aerosols. And we were ahead of the world. The first recognition, or first realization that SARS-CoV-2 was essentially airborne and not as essentially people were saying that by touch or other kinds of mechanisms. So airborne was the dominant way of the virus spreading. So how do you deal with it? And if it is airborne, and for example, in this particular room, let us take an example. If there is one person who is infected with SARS-CoV-2, it will take about 20 minutes to 30 minutes for about 70 to 80% in this room to get infected, because this air is circulated, right, in a room like this. And what we hypothesized at that time, and we actually showed, Rakesh's work showed, that if we were to sanitize the air before it enters the room, we have significantly less chance of infecting those many people. And based on this, the Central Building Research Institute, which is the CSAR Institute in Roorkee, we developed what is called as a National Building Ventilation Plan, which government very promptly announced, and all the government major websites, whether it be Ministry of Housing and Urban Affairs or whether it be Niti Aayog, it is displayed very prominently what should be the building ventilation plan. And the moment we actually put building ventilation plan, we got requests from many places that can you actually come and help us in sanitizing our auditoriums or things like that, or our rooms and all. And the first thing that we did, of course, we went and put in a place, a mechanism in the parliament halls, the Lok Sabha and Rajya Sabha, where the air which is circulated, before the air comes into the room, we have installed UV lights in the duct, which are concealed, but the air is completely sanitized by that. And what actually people in a room like this, what they get is a virus-free air. Well, the virus is inactivated. And that once again has been shown by Rakesh's work and how actually it can be inactivated. And I'm glad that many different places have adopted this. Most of the IITs have now put this thing in their auditoriums and all. And if IISER has not done it, I don't see any people from IISER. I think it's high time that you do these kind of auditoriums which are sanitized for air circulation. But apart from that, of course, every Vande Bharat Express that is rolled out today has this particular sanitation. And we had done this survey once again in the railways, Indian Railways, to show how in AC cabinets, where the entire air is 100% circulated, if that is sanitized in the duct before the air comes into the AC coach, it reduces the risk significantly, extremely significantly. So that's the place actually that we did, so that's air surveillance. The other environmental aspect, of course, is water surveillance, because we know that certain aspects of water, for example, wastewater in this case, has a potential to show you the spread of the disease. And we put in place mechanism in multiple cities in the country. Pune was a part of it, Hyderabad, Allahabad, and so on and so forth. And many places, we actually started wastewater surveillance very aggressively. And we were able to show at one point of time in Hyderabad, and Rakesh, of course, faced the wrath of the Telangana government because of that, was about 60% of Hyderabad population was actually infected at that particular stage. And it is actually an extremely important part of water surveillance. But environment, as I said, has many other aspects, and there is food that we eat is part of the environment, and many other aspects. And if we were to prepare for future pandemics, it's important that we pay attention to each of these aspects that I mentioned: air, water, food, and whatever we actually do must be actually regularly sampled and seen for the emergence of potential pathogens of the future. Especially AMR that Soumya mentioned is a potential time bomb that is ticking at this particular stage. And one of the major things that we need to do for AMR, of course, is surveillance of wastewater, surveillance of our livestock, especially the poultry industry, and so on and so forth, and how AMR actually can be tackled for the future. So the aspects of both surveillance and preparedness include aspects that I've just now mentioned: the genomic surveillance, the sero surveillance, and so on and so forth, environmental surveillance, and so on and so forth. The pandemic also actually has to recognize the multiple things that what we are actually getting prepared for. And that's exactly what we are doing in our strategic group, that we are preparing ourselves for what is coming, even during the stages of the pandemic. For example, we could see early on that there is going to be an oxygen problem in the country. And very quickly, our lab in Dehradun, the Indian Institute of Petroleum, came up with oxygen enrichment plant, the first of which we installed in Pune in the own chest hospital in May 2020. Unfortunately, by then the pandemic was, the Delta wave was May 2021. The Delta wave was already at its peak. So we actually fell short by a few weeks, what we ought to have done a few weeks ahead of that. But nonetheless, Very quickly after that, in about a few weeks, we were able to install more than 1,000 plants all across India, with a view that every district in India must have an oxygen enrichment plant that can be taken to a hospital close by. Similarly, when we saw that the hospital storage is coming down, that we are going to actually fall short of beds in the hospitals, how do we deal with that? And very quickly, just as the Delta was picking up, we started installing emergency hospitals all across countries. And these emergency hospitals were made at something like 7 days notice. So multiple places in Himachal Pradesh, multiple places in Punjab, in Maharashtra, and many other states in the country, which were falling short of hospitals, especially in remote areas, we were able to go and make emergency hospitals at a notice of about 7 days. And that was fantastic, because that gave actually 100 bedded, 500 bedded, 1,000 bedded, even places like Delhi. In the Safdarjung hospital, if you go today, there's an emergency hospital set up by us just in their car parking lot. So there's about a 500 bedded hospital in the Safdarjung hospital in Delhi. So the kind of things actually what we were able to do is see ahead of time what was coming up and be prepared for that and put in place mechanism where we can actually do it very quickly across. Now, one thing that we learned from the pandemic is, of course, the collaboration that Shashi mentioned across all agencies, across all the different kinds of stakeholders in society, industrialists, and policymakers. And we saw actually fantastic examples of this coming then. In the strategic group, we used to have regularly some of the major industrialists of the country who would come. For example, N. Chandrasekharan, the chairman of Tata Sons, he attended our meeting for about 2 hours. And we discussed at that time that issues such as, for example, if the pandemic reaches Dharavi, what we are going to do in Dharavi. And the Tata Sons immediately said that you tell us what to do and we will do that there. And then we actually had a lot of exchanges with them. And we put in place mechanisms by which the impact of spread in places like Dharavi, which is densely populated, would be much, much less. But Chandrasekharan is only one example. All major industries in the country, and I don't want to name them, but all major industries in the country, they actually came on board and they started working with us in putting in place most of the mechanisms that what we had thought of. The policymakers, the government, of course, I must say, was being monitored at the highest level in the government. And very frequently, we would have meeting at the very highest level in the country of the government to apprise of what is coming and how we are prepared for that. And that was fantastic. We had people who are coming in, a whole lot of society rose up to the challenge. We saw that during lockdown, there's a mass migration of people, right? And the people from the lower economic strata, as Soumya mentioned, were very badly affected. And we had to take care of them as well. And although the difficulties were insurmountable, what we thought then, many of the challenges that were there, we at least made life easier by involvement of people across the country. And many of these actually challenges were seen to be less challenging than what they appeared in the beginning, including the impact on the people who are migrating from one place to another, and how actually people rose to the occasion and providing food and shelter and whatnot to many of these people. So this particular pandemic has been an extraordinary lesson for all of us for the future preparedness. And I completely agree with all the points made by both Shashi and Soumya in this. And I'm sure the following speakers would reiterate some of these particular points. So thank you all very much for inviting me here, and welcome once again.
Thank you, Dr. Mande. I think we can open the floor to one question, if anybody has a question. Yes, please.
Curious, how can this all be scaled? I mean, I know that we've been doing this in bits and parts in multiple places across the country, but still we do not see that national impact that is.
Well, yes and no. We saw things happening at scale during COVID period. In India, the way everything was done, zero surveillance was done, was at a very large scale. Multiple people did, the TFR group and IISER and all, they did zero surveillance in multiple places. CSAR did zero surveillance 3 times across the country, and that gave us a view on how the disease was spreading. The vaccination was done at a scale. which was unprecedented in history. I don't think anyone in the world would believe that India could vaccinate so many people at such a short notice. But the surveillance mechanisms that have been put in place also are at kind of some scale at this moment. They need to be done much better, but all of it can be done. So I think if there is a will amongst all the stakeholders of society, whether it be industry or the society or the policymakers or the scientists and so on and so forth, things can definitely be done at a scale. And we are just seeing at this moment unfolding of different things at scale in a unrelated area. There's something like energy transition that what we are seeing is actually happening at a scale.
Thank you.
Thank you. I would now like to invite Dr. Gagandeep Kang, Director, Global Health, Bill and Melinda Gates Foundation, who is joining us online today from the US to share her views. Dr. Kang, I request if you can unmute yourself and switch on your camera, please. Thank you.
Thank you. I actually sent slides a bit earlier, so I don't know if you would like me to share them or you'd like to share them there.
We have the slides.
Okay, great.
Yeah.
Thank you so much. So I'm going to be, you've heard the speakers and they are all really eminent people who have had the opportunity to be part of decision-making internationally and nationally, who have driven a lot of the efforts that took place during COVID, and they've used that as a base to think about what we should be doing in the future. So I'd like to build on that theme and speak to you specifically about One Health surveillance for pandemic preparedness, and take maybe about 10 minutes to do that. Can I have the next slide, please? So as far back as 2021, Marian Koopmans, who has been a collaborator for a while, had actually proposed that we needed a One Health approach to think about pandemic preparedness. Obviously, when you have cases, when you know what you're looking for, then being able to confirm those cases, to do sequencing for known and notifiable diseases becomes feasible. But then if you want to think about being able to detect unknown pathogens, or think about things that are not usually on our radar, how do we think about doing that? So in terms of looking at One Health surveillance, a few things that were quite innovative were proposed. So one of them was looking at the metagenomics of slaughterhouse waste. So if you are, as we know, when you have domestic animals or livestock, then within slaughterhouses, you get a lot of waste being produced. If it was possible for us to look at pathogens from there, that might give us an opportunity to detect a signal for both known and unknown pathogens, without necessarily ascribing it to one particular farmer's livestock and thereby impacting his potential income. The other way was something that DBT has debated for a long time, which is thinking about vectors and whether we could actually squash a mosquito and see what pathogens dangerous to humans the mosquitoes might be carrying. So this is an unusual approach to One Health, but is certainly one that bears validation. Another way is to think about wildlife, and particularly if we think of birds who migrate across great distances, it is very feasible that those birds could be carrying pathogens as well. We've seen this in the case potentially of avian flu, but it's sometimes difficult to be in the right place where actual transmission between birds and humans is taking place. So is there a way of thinking about sampling that will allow us to detect these pathogens? And then thinking about possibly what has been done already and what we are thinking of doing is looking at metagenomics of urban sewage. Metagenomics is not easy. We had a significant success story with COVID-19 and sewage sampling, but we must remember that all sewage sampling that we do actually builds on a very successful public health program that was based on polio. So polio, in its quest for eradication, has been looking for signals of where polio viruses might be circulating for a long time. And for almost 2 decades, many cities around the world that are classified as high risk, including several in India, Mumbai, Hyderabad, Delhi, Calcutta as examples, they have been looking at their sewage in order to see whether we can detect a polio signal there or not. So all the surveillance that we did built on the fact that we knew that the environment could allow us, and particularly sewage could allow us to detect viruses that we might not necessarily be able to find just by studying patients. Next slide, please. So when we think about clinical surveillance or we think about serosurveillance, they tend to be slower. You have to get infected, you have to have disease, you have to come to a hospital, you have to make antibodies, and then we can start to look to see whether there is evidence of infection or not. If we think about environmental surveillance and a One Health platform that aims at environmental surveillance, maybe what we could develop is a scalable, low-cost alternative. And we know that we have done this very successfully for SARS-CoV-2. Now, the question is, do we let it slide? Or do we build on what we've got and think about how we can best use this for the prevention of future pandemics? Next slide, please. Could I have the next slide, please? Thank you. So as an example, not very far from us, SARS-CoV-2 in Dhaka septage actually started to increase before there was results that were available clinically. Now, this is one example. There are several such examples around the world where you could potentially get up to a couple of weeks warning before you started to see cases in hospitals. Next slide. So typhoid is another area where clinical detection is a challenge. Most typhoid presents as fever, and you take antibiotics, the fever goes away, you never know that a person had typhoid. So there has been a focus globally to identify sites in Asia and in Africa where we can develop protocols to detect a pathogen that is actually really hard to detect. Viruses, in many ways, in sewage sampling are really easy to get at. There is a lot of virus that is shed, and detection is simple. Typhoid, on the other hand, is a bacterium which is shed in very low numbers. So if there was a way to standardize methods for sewage surveillance that could tell us about typhoid, now we have at least type pathogens for both viruses and bacteria that we could look at for outbreak prevention and for signals of pandemics. Next slide, please. So there are lots of research needs. It sounds simple, it sounds intuitive, but having worked with both polio and typhoid and SARS-CoV-2 surveillance, I can tell you that the methods are a very real challenge. When you don't find something, does it mean that it's really not there? Or are my methods not working? If I do find something, where do I take that information to, and who ascribes value to it? I think SARS-CoV-2 was a real game changer for us. It's shown us that we have many, many opportunities to think about One Health surveillance and environmental surveillance. And if we can make a transition with all of the new technologies that we have, doing genomics, doing metagenomics, maybe we can make a difference to pandemic preparedness. Next slide, please. So in high-income countries, people were able to show that wastewater surveillance on airplanes could show you where disease was coming from. And it's been shown by modeling groups that if we could do wastewater surveillance of just 20 airports around the world, it would be possible for us to detect a signal from almost any country in the world. In other studies, they've shown that new variants that have been evolving can be detected without necessarily identifying the person or having that person come in and give a sample. So cryptic variants can be tracked through a sewer shed. And then, Italy was able to adapt its SARS-CoV-2 surveillance to actually detect Mpox DNA in wastewater. So these are just examples of showing you what is feasible if we can think about doing wastewater surveillance. Next slide. So there are many current and future use cases for single pathogens. Just doing a PCR on sewage is easy, but what we really need to aim for is metagenomics, doing an untargeted approach that will allow us to look at what is truly out there in sampling of wildlife or domestic waste that comes from areas where we think there is a risk of animal disease as well as human transmission. Next slide. And this is my final slide. I think we have been very fortunate with SARS-CoV-2, but we really have no time to waste. Rather than rebuilding and reinforcing the silos we've had so far, it would be great to take our lessons, learn them, buy into them, and develop all the partnerships that we need in a One Health approach to preparedness. Thank you very much for your attention.
Thank you, Dr. Kang. If there are any questions, I would request you to please ask your question.
Hi, Dr. Kang. This is Nikhil Fadke from GenPath in Pune and Ann Arbor, Michigan. It was an excellent talk. Thank you for that. A lot of things that you said resonated very strongly with us. But one of the things many of us face is the inability to get to people like you, because we have some of the solutions that you want, but there's always this large inability to reach. So, Dr. Shashidhara has been fantastic in enabling a lot of things for us, but is there a forum or something like that where many other people like us across the country can have access to people like you so that these things can move together and actually build it, because we have many of the things you're talking about?
Well, I think the important thing is I'm not a policymaker in India. You do have people who influence policymakers in the room. So those are the people that you should be talking to. You know, the technologies exist, the evaluations of the technologies can happen, but ultimately decisions are made by people who make policy for the government. This is about surveillance. You doing it or me doing it makes no difference. We need for the government to say, this is important to us. We will use this data. And perhaps this effort from the Principal Scientific Advisor's Office will be one step in that direction.
Thank you.
Thank you, Dr. Kang. I would now like to invite Dr. Sheila Godbole, Director ICMR NARI Pune and Director in charge ICMR NIV Pune, to share her views.
Good morning, everybody. And so good morning, everybody. I bring you greetings from National AIDS Research Institute, as well as the National Institute of Virology here in Pune. We heard a lot about our response to the pandemic from eminent speakers who've been part of this response and have done an excellent job and contribution to it. But it's also very important. We also heard from Dr. Shashidhar about the Pune situation. And we are very fortunate in Pune here that we had two institutes of ICMR that contributed to a large extent to this pandemic. NIV with the virus isolation, laying the ground for the vaccine, testing the vaccine in the preclinical stages, and the diagnostics for this pandemic. NARI for its clinical work in therapeutics and its clinical work in vaccine development. One vaccine that received EUA, and of course, leading the solidarity in India for the country. So this is where we come from. And I thought today I'll talk a little bit about disease surveillance in the context of pandemic preparedness. And when I first heard Dr. Gagandeep speak, and it was an excellent piece on wastewater surveillance. But what I'm going to be I thought I would be repeating everything she said. What I'm going to talk about is bring out a few aspects of how are we going to break the silos and what we really need to be doing as we move forward. Can I have the next slide, please? Yes, thank you. So traditionally, this is the surveillance that we have been doing, whether it's based in the laboratory or whether it's based in the clinics. So we have one of probably the best, coming from the world of HIV, we've probably got one of the best surveillance systems in the world for HIV. So it was initially intended as an early warning systems to look at outbreaks, which might lead into epidemics or pandemics. It also helps us to monitor interventions, and it also helps in planning and advocacy, and as Dr. Soumya just mentioned today, in education of both the community and the people who might be responding. Can we go back? Thank you. So, however, this traditional established methods of surveillance have always been something that we've only been catching the tail of the tiger, or occasionally we've been riding it. We've never been able to get beyond it because we did the surveillance, as Dr. Gagandeep mentioned, when something was established in the human beings. And we continue to monitor a problem that has already been existing. This is what we have been doing all along. But this is what we distinct causal elements. And then we have to identify where exactly we can go in to sample for the information that we require. So we do know that what we are going to see in the future is because of the impact of humans and their human activity on the ecosystem, on the animals and the birds who are both domesticated and captive. And that is why we heard about surveillance from slaughterhouses. But we have also important to do some surveillance in, say, bird droppings in sanctuaries, where the migratory birds are coming in every year, very, very periodically, and we don't know what they're bringing and from where they're bringing this. So we have to go to our sanctuaries, we have to go to our zoos, we have to look at the uncultivated and the cultivated areas, the shared environments, the shared risks, and finally what happens is the impact is always going to be very, very skewed on the human civilization. So what is very important? We just heard one example of using wastewater or slaughterhouse waste to look at some markers that might help us to foresee something and hopefully predict something that's happening. So now surveillance is a constant state of alertness. It is for something that's new, that's different, that's unusual. It could be in terms of organisms, the constant surveillance that's happening through the laboratory networks, the excellent VRDL networks that has been set up by CMR. Are we seeing something new, something different? The surveillance among animals, which is various ministries which are involved in surveillance, not just in, but what is the impact that they might have among humans? Earlier today, we heard about AMR surveillance. AMR surveillance in animals could be something that predicts what is happening or what is likely to happen in the humans, not very far away from when we identify what is happening. The syndromes, clinical syndromes, are they changing? Clinical syndromes in humans and clinical syndromes in animals. The change in causality of these syndromes. So we need to be identifying the syndromes and what causes these syndromes and have a constant surveillance that's ongoing without feeling very complacent. And the patterns among both, I talked about humans. And what are these patterns we have to look at? It could be deaths. It could be hospitalizations. It could be hospitalizations, ICU admissions. It could be drug utilization patterns. It could be sick day patterns, both in schools or in workplaces. It could be animal illnesses or bird illnesses that are clustering in places. We have to look at carriage of viruses and parasites in different animals, and something that's going on but has to be scaled up in our country. We have to look at the climate. We have to see what's happening to the populations in various areas where we reach them, and we have to track our pollution. So this is an example of KFD. Everybody knows the story of KFD that was identified by NIV. But what was important was it's the deaths among the monkeys that first leads to suspicions of what is happening in these forested areas. So surveillance has to be multi-component. It has to be multidisciplinary and multi-sectoral. And there has to be very, very close coordination, both in the private sector and in the public sector. That is something that we continuously need to recognize, because the public sector is not going to be enough for our country. And there is a large component of health intelligence in this as well. So looking at information that's coming in and screening for it and trying to identify patterns and trends. And what about bioterrorism? It's always something that we have done inadvertently, but it could be something that happens very, very purposively, that we need to also be careful about. And therefore, surveillance now is about big data analytics, and newer methods of understanding. We may not need to identify the exact organism completely in the beginning, but we need some tests that are indicator tests that probably tell us what is happening that is different. And we need predictive models and predictive diagnostics. So this is an example of what is currently happening in the country. There's an ongoing survey of bats that's constantly happening, which is being conducted by the National Institute of Virology. We are using our mobile BSL-3 laboratories for this purpose, and this is happening all over the country. And we are trying to look at the blood of the bats that are captured and looking for antibodies for the Nipah virus in these bats, and also looking for the virus in these bats to see if we can possibly predict future outbreaks of Nipah. Similarly, there's a constant ongoing surveillance for avian influenza, which has a lot of impact. It has an economic impact as well as a potential impact for human beings. So this is a well-oiled mechanism that's ongoing, but these smaller surveys are not going to be enough as we move into the future. We have to look at more places, more locations, more animals, and more ways of identifying samples that we can use for surveillance. What we need, most importantly, no data is useful just collecting it. We need to be actually looking at it and looking at it sensibly and constantly. And therefore, having few key indicators which we can look at in real time. And these indicators coming from sub-district level. Dr. Soumya alluded to the collaboration that has to happen at all levels. And we need that capacity both locally, like we had here, as well as at higher levels, at state, because after all, health is a state subject, and at the central level. We need to have easier methods of collection. We need easier methods of transport and easier methods of directly getting the data into the databases, which is a very quality data, so that we can look into it. When we've done a lot of secondary data analysis for various programs, particularly for elimination. In fact, at NARI, we've recently set up a division for disease elimination. And one of our focuses is to look at data for elimination. And what we see here is the data is not ready for a year or two for people. They're not ready to share the data because they're still doing the data quality. They're looking at the quality of the data. They're still uncertain. And by the time the data comes in, it's about a couple of years old. And that is not what we want moving forward. So we need simple, robust data collection methods. We have to minimize the manual inputs into these data. We need to have data and intelligence sharing both within our country. And with this platform of the G20, we can at least move in for a more regional and beyond the regional borders of data sharing. We saw this happening with the tsunami. So very quickly, we were able to establish the early warning indicators for tsunami. So we should realize that this is a tsunami that we are getting ready for, and we need to go across borders to look at data. Because yes, there is going to be self-interest always when it comes to response to what is happening. But that self-interest should not begin even before that, because we've seen that the world is truly flat. I kept reading Vasudhaiva Kutumbakam over here when I was sitting on my chair. And that is exactly what we have to, that's the principle and the ethos of this One Health surveillance that we have to see. So we need a lot of tools. And that was also mentioned by Dr. Kang earlier just now. We need good methods of data, sample collection and transport, preparation so that we preserve what's in the sample for us to be able to test. Good point of care diagnostics are always the best, and good networks that do these diagnostics and data sharing. We need good laboratories, but not too many of them, that can handle high-risk pathogens, and good networks of these BSL-3 and 4 for isolation, as well as genomic surveillance, which is going to be the way forward as we move forward. And the reagents, that too was alluded to. We have to be self-sufficient in what we need for our diagnostics and be able to scale that up as we move forward if required. So under the PM Abhim, we have been establishing a series of BSL-3 laboratories. One is coming up right here in Pune as a BSL-3 that is being planned under the PM-ABHIM program at Nari. In addition, we are setting up the mobile BSL-3 everybody is aware of, which is already in use in many parts of the country, but this can never replace a well-established self-standing facility. And then we have the NIV, which is being cloned into 4 different NIVs, one in Bangalore, one in Dibrugarh, one in Jabalpur, and one has just been planned in Jammu. So this will serve all the different regions of the country and help the current NIV in Pune do its work much better and faster at all the locations. In addition, the National Institute of One Health that is being established in Nagpur in collaboration with MAFSU was an institute that was planned as a subunit of the National Institute of Virology, but has now been dedicated to the nation. And now will house all the different ministries and the people thereof who are involved in the science of One Health, who will come and work together. This will have both a BSL-3 and a BSL-4 facility, and the work will begin very, very soon. So we have had a lot of initiatives in One Health, and I'm showing the ones in which NIV is more involved in. We talked about that we have begun surveillance for various at various places in India in a pilot mode so that we can learn and then scale it up to much larger surveillance. And the testing algorithms are being set up to look at different syndromes and then the possible pathogens and how we can possibly do the diagnostics very, very quickly and using tools that look at multiple pathogens at the same time and the development of those, which is ongoing at NIV right now. So there are a lot of research needs for surveillance, and I'm only focusing on those that begin from the field and come to the laboratory. I talked about many of them, so I'll just go ahead. In terms of disease modeling, we are now beginning an initiative at Nari where we are planning over the next 3 years to train about 100 modelers and maybe 50, 60 modeling teams who might be able to do some basic modeling, working with the health program, as well as having academia, the public health programs of the different states, and some good modelers, bringing them together so that they can respond very quickly to the data that is coming in from different parts of the country. So that is something that we have, a small alphabetical research needs. And this is going to be an ongoing list that encompasses the gamut of the alphabet, but we have to constantly be thinking about what we can innovate for each and every single one of the needs that will come for surveillance. Thank you very much.
Thank you, Dr. Godbole. Any questions?
Hello, Dr. Godbole. This is Akanksha. I'm a B-cell biologist at NCCS Pune. My question to you is how accessible it would become for scientists of other institutes to access BSL-3 and 4 facility and develop assays in collaboration with the ICMR for achieving this goal of One Health.
So this is an initiative that ICMR has begun. It is throwing open all its laboratories to the public, to academia, and to other academic and research institutes, where we can share our facilities with people who would be interested in working. And we see a similar concept for the BSL-3 across India that is being set up under PM-ABHIM as well. So you must have heard that this was actually announced in the budget speech, ICMR's initiative for sharing its laboratory resources across the country. And we will be doing the same. For Nari, I can always promise you that it would be available. Thank you.
Thank you. I would now like to invite Dr. Rakesh
Tripathi
Mishra.
has something to say, I think.
Oh, I'm sorry.
Yes, I think every lesson that we learn is always applicable in the context of where we can use it. And I think that was also mentioned earlier today in one of the earlier talks, that it's while we look for the disease X, we have to look at our endemic diseases. And probably there are some lessons that we can take up for tuberculosis, some of the extrapulmonary tuberculosis diagnoses. Maybe we can look at other ways of diagnosing or looking at them. But there, the immunological component is so different. It is not so much about finding the infection elsewhere as finding the reasons for why it's coming up, probably. But yes, broadly we can and we should.
Thank you. I would now like to invite Dr. Rakesh Mishra, Director of TIGS, to share his views.
Okay. So I'd like to begin by thanking PKC for organizing this. It's very important that we continue talking and pushing for the agenda of surveillance and One Health. Very, very important. And you have already heard a lot of background and why it is important and why it should be done. What I'm going to do is to give you some flavor of what is happening in Bangalore and what is the future, what we are doing in well, you will change or I will change? This is not working. Okay. So we are part of Bangalore Life Science Cluster, where NCBS, INSTEM, CCAMP, along with the TICS, we operate within the large campus of University of Agricultural Sciences, and it's a extremely advantageous arrangement for all of us that there is seamless connectivity and sharing of resources, so we can do things in really a very effective manner. And I'm going to show you things which been possible because of this environment of BLISC. So before that, I can bet most of you don't know what is TIGS. So Tata Institute for Genetics and Society is a program-driven organization that uses cutting-edge science to solve societal problems. It's a non-profit organization, mostly funded by the Tata Trust. And we have 3 programs, infectious disease, rare genetic disorders, and crop improvement. And because today we are talking about infectious disease, we have 3 verticals in that: the environmental surveillance, disease ecology, antimicrobial resistance, and vector control. And as we know now, because all these things are coming together and in many different aspects. So there is increasing, I will go fast, and because other speakers have already spoken, there is an increasing threat of infectious diseases for a variety of reasons, as Shashi started saying, the mobility, population, and so on. So we are now really facing a threat all the time of emerging or new diseases, as well as the ones that are endemic. They can become problem very quickly if we don't address them, or it's very prudent to be prepared for that. So what so I give you an example of Bangalore, which probably will become also replicated in many other places. Things are also happening in other cities. So here we have an integrating human and animal health with surveillance and disease ecology in a global urban center, which is Bangalore, supported by BEST, which is the Bangalore mega cluster, maybe equivalent to PKC, and also supported by principal scientific advisor. So here the Bangalore One Health model is focusing on converging governance, surveillance, environmental and vector surveillance, disease ecology model. And we are having regular meetings. As we speak today, we have a meeting of Bangalore One Health going on. So it's very active, and we are building around the existing facilities and planning for the future. So this was one of the first meeting when One Health National Agenda more than a year ago was arranged by in IISER. Art Park was heavily involved. We have colleagues from there and PSA office. And I think few months back, there was a launch of One Health Bangalore City consortium. And I'm very happy to say that even the local administration is so actively involved. So is the case of Pune, which I have been hearing, and that's not the case in many other cities. And the idea is to have periodic meeting of stakeholders, mapping, data management, and of course, the dengue is local problem for the, not really local, but a major problem in Bangalore city. So we are having a special focus on that. So this is just to show you that there is a lot of activity with the support of existing institutions, other agencies, and the local civic bodies, which is, they are the stakeholder and they have to be there to accept and also make use of the data that we generate. So I'll now go very briefly and give you a flavor of what is happening. I will not go too much into the data. We can discuss that just to give you a flavor of what is happening, something which we can feel happy that this is technically possible, and others we can be concerned that what kinds of problems we are actually facing when we start looking carefully. So wastewater surveillance is actually a complicated issue. Where there are STPs, it's relatively easy, but then there are open drainage in many cities. Most of the sewages goes through open drainage, and then there are water bodies, which can also be a big problem. We have already seen this in various cases. So we are focusing on Bangalore and Hyderabad, and we have a very close connect with the Pune surveillance system through the Rockefeller support, which I will just tell in a bit. But as Shekhar also mentioned, we started doing air surveillance some time back. Because of the lack of time, I'm not going to explain, but we are very strongly pursuing this and expanding it to other infections beyond COVID. And we think that it can be a useful thing for surveillance, like what you just heard Dr. Kong saying about airports. So many times, in addition to wastewater, air surveillance can be very, very handy. And we also want to correlate this with the vector surveillance and clinical surveillance and really develop robust models of what is the pathogen status in a given ecosystem. So as I was mentioning, this effort is very generously funded by Rockefeller Foundation, which is a 4-city cluster. So we call it Alliance for Pathogen Surveillance Innovations in India. And so we have in Delhi, Ashoka University is now the main institution. And then we have in Bangalore, in Pune, and in Hyderabad. These are 4 major city clusters, and we are in very cooperative manner and exchanging data, protocols, and information. We are focusing on environmental surveillance for disease monitoring, which is COVID, and beyond COVID, let's lot of emphasis on microbiome and AMR. And we also have a focus on skilling, indigenization, knowledge dissemination, and putting everything in public domain, which should happen in coming days and weeks. So I give you some examples of how useful this surveillance actually can be. You heard from previous speakers, and you also heard that we can have 10 to 12 days early warning of an infection, particularly in case of COVID. So this is the data from Bangalore's 28 STPs, which we continuously do for now a couple of years we are doing. And this is, you can see, we are plotted in July. And this is the water load, viral load in the sewage. And this is the test done in the clinics, the people infected. As you can see, this is the third peak, the major one, and then it is flat. What we have not seen which we call it the invisible peak. We just passed March and April, which was probably far bigger than even the third peak. But we didn't see in number of cases that because we were not testing anything. But good thing was that we are now so well protected that this is like any common cold. But we have seen the biggest peak of COVID just a couple of months back. This was there and we were sharing with BBMP constantly this data, and they were aware of it and kind of waiting if anything needs to be done. So that was with STPs, which is very organized, and you can collect samples and so on, and estimate very nicely. We are also doing in parallel with in collaboration with CCMB from the open drainage system. And so this is the data, cumulative data of 20 different open drainage system spots from where we collect samples regularly. And you see the peak, and this is I was talking about the fourth invisible peak. We can measure really well, even in open drainage system. So we are continuously comparing and collecting information from the STPs as well as the open drainage, because many places you will not have STPs. Even if they are there, actually they are not functional. So you are better off collecting data from the open drainage. And this, I forgot to tell that we constantly do genomic sequencing also, so we know what kind of variants are going around and so on. So that was the SARS-CoV-2 surveillance. What you are seeing here is an exploration of the other virals that are there in the wastewater. And this is amazing. What you see, different countries, are 3 different STPs, it's Bangalore data, and it shows variety of viruses. And SARS-CoV-2 is this color, so you'll find somewhere here is a minority, and most of the viruses are something else. So we have to we don't know, of course, many of these viruses are known there, as you see, their names are written. So we have to follow them up constantly over, in fact, in a continuous manner. And because of the genomic approaches, we can actually see if some of them are changing. And if some of them are changing, and those that are changing, their proportion is increasing, so we should get alert and do something about it. And we know from whether you can see that there are changes in these are different STPs have different profile of their viral load. So this can also tell about locality, what is happening, and if there any intervention is required. So very, very useful information that now is coming. And this is something to be worried. You just heard that IISER is doing surveillance for some time. And now we are doing our open drainage as well as the STPs. And this is profile of the AMRG that is there present. You can see various antibiotics will not work on these bacterial isolates. So this is from the metagenomic analysis using a specific panels, but we can do even for unknown or the things that are not on the panel, which is quite is simple to do now. But this gives us really a concern that so many AMR things are are clearly visible even in the wastewater. So what we are doing now is comparing this. Okay. I have one slide later, but this is extremely important because these are all now beginning few months data. Now we are doing from Hyderabad in open drainage. We see similar situation emerging, and I'm sure in other places it's same kind of thing because we have whatever situation misuse, but antibiotics is a big problem. What it does tell us is what is more and how it might be changing. So these are this is actually different STPs, all 28 STPs. You see fairly consistent picture, but we have noticed, at least in Hyderabad, that different period of time, this profile changes a little bit. So we have to now map it with the data that can come from the hospitals, go and we are having now interaction with the hospitals. We can collect their STPs and measure there because they are likely, I mean, supposed to be the source for such things because of regular use of antibiotics there and so on. So this is something we can see that we have tools, but now we need more determination to accept these things, follow them up, and do the needful. Otherwise, we are waiting for something disastrous to come. And this is the another surveillance which we do in the Bangalore city, and that is for the mosquito, their larval habitat. And that's because of this dengue problem, we actively involved, and a lot of cooperation from the city authorities also. And we have mapped, this is now soon going to be published. But what it has given us that where these mosquitoes are, and also in what kinds of larval habitat we find discarded tires or buckets or discarded coconut shells where you can they can grow. So these things also help us bring some awareness that can reduce the this problem. So I was just saying that we are now beginning interaction with the hospitals. So we have now agreement with BBMP, and through which we get samples from about 150 healthcare centers of the government, and we map dengue serotypes and chikungunya, and this is their maps. Just to impress you that these things are now possible to do, and we can map this and correlate this data with the environmental samples, and then see what we are missing. Because hospital data is only tip of the iceberg. Most people don't go to hospital because they have to go to work. They take a tablet and go there. And most of time, infectious disease, we recover on our own. We don't need really treatment, especially viral and those things. So we never know what is the level, but environmental sampling gives us the correct picture. So now, just to finish, vector surveillance is another aspect in which we are now doing serious planning. And thanks to motivation by Sindhura, I hope he will be coming now after this. So we are now really making plans of and strategies for the large scale vector surveillance, originating in various animals, and there are various ways of transmission, and vector is one of them. And you just saw in the previous talk that sometimes animals survive the early warning also, particularly in case of KFT, you can actually get. So if you are aware and alert, you can keep getting these early warnings. Now the question is how you should be aware, how you should be alert with this, what needs to be done. So you have heard already that we require a lot of synergy to communicate, to coordinate, to collaborate with others. So this is and different vectors have different habitat, different disease, and so on. So we are actually developing a strategy of how to do effective zoonotic surveillance, especially for the vectors. And hopefully in few weeks, we will come up with really proper documents. As I said, we are doing in coordination with the PSA office, and hopefully we will have a strong at least policy document that can be debated and implemented, because it's extremely important now with the way we are approaching the natural environment of other animals, and so much of connectivity and globe shrinking in terms of reach. Within few weeks, African air is shared by us sitting in India. So, I mean, COVID has shown us, right? There's Omicron in 4 weeks all over the world. So this will tell us where is the pitfall, where are the obstacles, and how to avoid them if we can't eliminate them completely. So with that, okay, so as I said, we are doing a lot of advocacy and other things so that whatever we do reaches to relevant people. And important is community engagement. If you have new technology, you have to take it to people, take it to policy people, to all over the places, because any new technology requires a lot of pursuing. Another very important thing discussed also, that you can develop interesting technologies, but how it can be made long-term tenable and sustainable. Particularly in this case, we require sampling strategy, minimum or not too much, otherwise a waste of resource. indigenization, because we cannot be importing all the thing all the time. And Shashi mentioned how we have been successful in doing that. COVID testing came down, and there are some major players sitting here. I mean, 100-fold less. So, so we can do that. And in the service model, labs cannot be doing surveillance constantly. Labs are there to do research and do new things. And we cannot keep motivated our scientists, keep doing wastewater surveillance forever. So we need service system. Private sector has to get involved, provide services to municipalities so that can be implemented as a essential component of the any municipal corporation and so on. And we have to include wastewater, air, zoonotic surveillance, and I mean, all speakers have already discussed about it. So thank you very much, and I look forward to more discussions.
Thank you, Dr. Mishra. In the interest of time, we will not take questions. Dr. Mishra is here for the rest of the event, so please feel free to talk to him during our break and the lunch break. Before I invite our next speaker, I have an administrative announcement. I would like to request the owner of MH12 PH6323 to move their vehicle, please. MH12 PH6323. Thank you. I would like to call upon Dr. Sindhura Ganpati, PSA Fellow, Office of PSA, to share his views.
Thank you. Are you able to hear me okay?
Yeah.
Okay, thank you. I can assure you that vehicle is not mine. So, good morning, everyone. I'm really sorry I'm not able to be there in person. Would have loved to be there. And I will not be spending a lot of time speaking, just hit some highlights, because it's very difficult to follow such distinguished speakers and colleagues and accomplished people that just came before me, who are also good friends and colleagues who are working in the space of One Health that we are setting up now. Few things that I wanted to just touch on is the amazing trajectory this whole space of One Health has come. 10 years ago, when I used to go to conferences that are themed One Health, used to be mostly veterinarians complaining and crying, people are not listening to us. And COVID has changed it dramatically, and now it is in the public conscience. And now we have the problem of the riches, where you cannot make a turn without hearing the word One Health. And the problem of the riches in the sense that everything can be covered in One Health, because it is such a broad theme and topic. In its broadest definition of human, animals, planet, it becomes quite hard to find things that can be somehow force-fitted into One Health. Now, the challenge with that is that it loses focus. So what we have now is an interesting time where we need to go beyond the limited thinking that everybody agrees that we need this comprehensive approach. But where we are now, where the next challenge is, how do you turn those into specific solution sets that get benefited because we apply the tag of One Health, or the theme of One Health? So what do I mean by that? Just because I was doing some research in the past, now One Health is a selling point. Let me attach a tag of One Health because that is now in trend, will not really benefit our advancement of thinking. What will benefit truly is the application of One Health theme actually gives us a different perspectives. Now, that is the constant check we need to ask ourselves every time we apply that tag. Is it just a tag for whatever we were doing before, or does it actually change the way we look at it, giving us a new perspective, new solutions, new way of doing things that may get us to the solution? So with that, I am very happy to see the activities of PKC. I've been quite impressed, even in my few visits I've made there, which is truly embodying that challenge of bringing everybody together, but keeping it focused as a science and technology cluster. And as Dr. Maini in her opening remark mentioned, the context for this is twofold. One, at the national level, there is a national One Health mission in the making, and it has been in the making for now 9 months to a year. And that is what it takes for such broad effort to be catalyzed. But I'm very happy to say that with coordination from Office of the PSA, but true engagement across departments. Now we have participation from pretty much all the science funding agencies, DBT, DST, CSAR, ICAR, ICMR, and all of those, Department of Pharmaceuticals and beyond. We have Human Health Ministry and its constituents, whether it is NCDC or the ministry itself or ICMR, DHR, and Animal Husbandry, the DH, the Department of Animal Husbandry and Dairying, as well as Ministry of Environment Forest. But we also have NDMA, because the lesson we learned is we need to look at these as health disasters, not just floods and earthquakes, but these are also disasters. And the amazing progress India has made in addressing floods or hurricanes or such can be brought to this. So that's why NDMA's engagement will give us new ways of thinking and doing this, both for human diseases as well as animal diseases. And finally, defense side as well, because biosecurity is an important aspect of all of this. The only distinction between when we look at something as a biosecurity versus our routine One Health aspect is how we got to that outbreak, whether it was intentional or accidental or natural. And so everything else, surveillance, outbreak response, preparedness, with whether it is tools such as vaccines, diagnostics, everything pretty much remains the same backbone. So, so with this, the other aspect of why we are here is the CSAR, the Chief Science Advisors Roundtable, which is a newly started G20 event or a forum for discussion of this. We had one meeting where One Health was discussed. I presented the possible themes which could be taken up by G20, and there was very broad convergence. And globally, it is quite an active field, One Health is. Now, the challenge is, what are some aspects and topics? Everything we are going to be doing in India will not be applicable for G20, because there are some things that may or may not suit. But the areas that Dr. Maini mentioned, better surveillance technologies, environmental surveillance technologies, whether it is assays or sampling methodologies, better data standards when we have to converge data across seemingly diverse areas, and having a network of these institutes that are involved in One Health, so that there is constant exchange of ideas and places where we need to turn to, which became very critical during COVID crisis. All of these were proposed as possibilities, and there was buy-in from most of the G20 countries, and those are what we will be taking up in the next upcoming meeting in Gandhinagar. And hopefully this will continue when India hands it off to Brazil in October. Now, in the National One Health Mission, the main focus being integrated disease surveillance, including implementation of newer methodologies such as environmental surveillance, having better pandemic preparedness of both human pandemics as well as animal pandemics, joint outbreak response across these sectors, human, animal, environmental sectors, and all the enabling activities, whether it is R&D or regulatory approval process, data and linkages, all of those are part of the proposed One Health Mission. And it has a steering committee chaired by PSA, Principal Scientific Advisor, with membership from all the secretaries and DGs. And they have been meeting very regularly, approving things, including the what Dr. Sheila showed, Honorable PM paying the foundation stone for National Institute of One Health. The backstory there is, it was originally conceived as a Center for One Health in ICMR, and ICMR Institute. But in the very first steering committee, with all the DGs and secretaries present, the DG ICMR said, I would like this to be an anchoring, coordinating body that is dedicated to serving the One Health mission, as opposed to being known as an ICMR issue, which was received very well, and even the name was changed, and the focus has also been evolved to be an anchoring body, so that there is an institutional framework for the National One Health mission. And this institute will be managed by collaborative effort with participation of all the secretaries in the administrative governing as well, which has been conceived. And the other example, the BSL-3 network, for example. So there are many BSL-3 and upcoming BSL-4 facilities, but we do not have a national connected network. And that is one of the concrete examples of how One Health Mission will be taking this up. DBTs, BSL-3 facilities, ICMR's BSL-3 facilities, CSARs, ICRs. So each of those have been asked to nominate their currently functional BSL-3s. So we will start with a handful of those that are working today. Set up a national network with harmonized SOPs and regular engagement and regular auditing of those, and a secure data layer, so that outbreaks from any sectors, from any parts, should be able to be handled from any of these labs, regardless of administrative boundaries, that are capable and suitable for handling those samples. Now, seems pretty obvious, but it will change fundamentally certain things when we do this. For example, Ministry of Environment Forest today do not have their own dedicated BSL-3s. Department of Animal Husbandry has one. Now, with a national network, suddenly they will have access to 25, going forward, more can be added. Now, that will fundamentally transform this into institutional framework to a national framework. And it will also give us longitudinal sense of what were all the outbreaks that happened, not just in human side, but in the interface of human, animal, environment. How many anthrax outbreaks happened in the last 2 years? Going forward, once we have this running, we should be able to longitudinally track this. And also continuously, we can be in a continuous improvement system that these labs functioning at the international standards. Now, I don't want to spend a lot more time on this. The goal is there is islands of excellence here. Where Rakesh showed, they have a unique capability in pigs on focusing on vector transmitted diseases and how the vector biology works. Similarly, VCRC and ICMR. So we need these groups that have developed such depth in these focused areas to advance those fields, but connect this to the larger overall One Health activities. Now, PKC will likely be taking up or has already been taking up various efforts in disease surveillance. In Bangalore cluster, they are focusing on some of those, including animal disease. How do we use environmental surveillance for foot and mouth disease, which is a national priority, right? But we do not have this methodology applied to that yet. How do you use milk or slaughterhouse effluents or animal traits to detect which serotypes of foot and mouth disease is spreading in the country, which will have huge consequence to predict it much better, and also how this national program handles vaccination. Therefore, linking these will be very critical. The reason why I emphasize this is integrated word is used in different meanings or contexts. Oftentimes people think of integrated in the form of, say, even how human health sector integrates it, integrating vector-borne diseases with non-vector-borne diseases. That is a challenge also we need to overcome in human health. How to integrate surveillance programs across human diseases itself. But then we can go one more step. What most of my human health colleagues oftentimes think about it is from a public health standpoint. So even in the name of One Health, we are looking at zoonotic disease. There, the context is more, how do we prevent TB or anthrax, rabies affecting human health from integrating animal and environmental sector. which is good progress, but not complete. The reason because we are still taking the public health standpoint when we do that, which means these diseases come to us humans. How do we address this by making wildlife colleagues change their ways of doing so it helps us? What we do need in this One Health effort is truly go beyond so that TB, tuberculosis, how does livestock sector think, which is more of a productivity concern, trade concern? How do we address it from their perspective? Anthrax or TB in wildlife is a conservation issue. And how do we meet them where their goal is, which is the conservation side? So that is what this One Health mission is taking, which is truly taking the perspective of not just public health, but also productivity and trade concern of the livestock as well as conservation of the wildlife. Now, with this, I would like to just come to the end of my remarks, which is taking this approach has practical changes, not just a theoretical or some more words, goes beyond words. For example, avian influenza, going beyond human health cases will enable us to look at not just livestock side, which is the poultry farms surrounding the places where they need to think about detecting the cases early, culling, provide compensation. There is an entire mechanism that works, that and it has different incentives. The compensation provided, if it is market price, below market price, the poultry farmers may be less incentivized to report, right? If I get the compensation low, I don't have proactive desire to report, and the government comes and culls my poultry and gives me a below market price compensation. Now the reverse can also be true, which is if the prices are low and market prices are very high, the compensation prices are high, then it can lead to perverse incentive. In the sense, they would be hoping to see some cases so that I get better compensation. So incentives are very important consideration on how we build systems so that it sticks and does what we think we can do. And this is where technology also comes into play. Expecting people to report outbreaks will not completely solve our problem. That is where technologies such as environmental surveillance, genomic approaches will be very crucial, because they, while reporting is needed, these technologies are somewhat agnostic to the systems coming forward and saying, I have a case. And this also helps the situations where some of the cases can be subclinical, so you may not detect. So this is why taking this kind of truly integrated, holistic approach will have practical consideration. And I've been tracking this across the world and different countries, taking up this in different contexts. And have had many of these countries describe this approach that we are taking in under National One Health Mission as being quite interesting from their own words, truly beyond the comprehensive ways some other countries are taking it. But we also have lessons to learn from some of the other countries, because good ideas can come from everywhere. So G20, CSAR, as well as other forums of G20 discussing this provides that unique platform. And the science and technology clusters bringing it home for PKC is like a real life example distilled down to one local area, where all of these sectors coming together, converging, and in a practical way, showing the way forward how this could happen at other places in the country. So thank you for all the work that we have been doing, and I really appreciate the engagement of all the super fantastic experts that spoke just before me, who have been thought leaders as well as guides and mentors for me and the office of the PSA as well. So appreciate all of your participation. Sorry I was not able to attend. and I look forward to continued engagement. Thank you.
Thank you, Dr. Sindhura. Thank you for taking the time to be with us. Before we break, I would like to just call Professor Shashidhara onto stage to felicitate our speakers who are here in person today. I would like to invite Dr. Shekhar Mande. I would like to invite Dr. Sheila Godbole. Thank you. We will break, but I request, I request Dr. Rakesh Mishra to please come. I assumed you're here with us till the end, so. We'll gather at in the terrace, joining to this room for a quick photograph, and then please feel free to go and see all the posters that our students and researchers have displayed. We'll reconvene here at 12:25 for our next session. Thank you. Sindhura, we are taking a break, and we'll reconvene in an hour from now.
Thank you. Yeah, Shashi can bring my gift. Come back to Bangalore.
नहीं अभी ये सब connected है. Oh, so everything will be.
Hello. Hello.
Hello, everyone. I hope you all had a good break. We'll start with the next session. So over the past 2.5 years, PKC has worked towards building and supporting health ecosystems for disease surveillance in Pune. PKC was instrumental in setting up a consortium for genomic and wastewater surveillance for COVID-19, and we're now leveraging that knowledge and experience to other disease. Keeping in mind our aim of building a robust disease surveillance system, we have curated a distinguished panel that represents different aspects of public health to discuss strategies for disease surveillance. I would like to call upon stage Dr. Rajendra Wable, Dean YCM, Hospital and PG Institute. Dr. Uma Aisola, Director, Communications Access Health. Dr. Vidya Mave, Co-Director, Center of Infectious Diseases, John Hopkins University. Dr. Pradeep Avde, former State Surveillance Officer, IDSP. Dr. Raj Shankar Ghosh, Senior Advisor, Public Health Foundation of India. Dr. Umesh Shaligram, Director, R&D Serum Institute of India. And Dr. Akhilesh Mishra, Director of IISER. The topic for the panel discussion is perspectives on building robust public health strategies for disease surveillance and its potential impact. Each panelist would provide their views on the topic in 7 minutes, after which we will open the floor for questions. First, I would like to invite Dr. Rajendra Wable to kindly share his perspectives on the role of government hospitals as being the first responders to disease surveillance and being the front runners for integration of government programs such as IHIP.
Good afternoon. Greetings to all. Dr. Wable, I'm Dean at PCMC's Postgraduate Institute. I'm Dean at PCMC's Postgraduate Institute and YCM Hospital at Pimpri. Regarding the two things that were put before me for a response, about first thing is what response of government hospitals for surveillance purposes. In that, I would like to differ as first responder for government hospital, for broad specialty hospitals. First responder cannot be a proper concept. First responder has to be at public health center levels, at private practitioner levels. Now, data from public health centers, government mechanism can work upon that to get data from public health centers. But problem is getting data from private practitioners, general practitioners regarding occurrences of communicable or non-communicable diseases. Now, towards this, the data from hospitals or government hospitals, I'll say, will be coming in only after the severity of communicable or non-communicable disease is beyond the reach or treatment by general practitioner or at PSC levels. We can just compare the things like broad specialty hospitals or hospitals with more than 500 beds. They come into picture just like when army is being called. First, it is the police which has to deal with the law and order situation on the ground. So that is at PHC level or general practitioner levels. Then if they are not able to control the things, then maybe CRPF is called in. And later on, broad specialty hospitals, they come into picture only when the severity of occurrences of either communicable or non-communicable diseases increases. Now, towards this, I'll say that National Medical Commission about a year back has instituted its digital mission mode project, whereby it has put in place 3 components of this digital mission mode project. One component is online Aadhaar-based faculty marking system. Second is hospital management system, which I am trying to highlight in this, wherein the entire data from the hospital will be available at the central server of National Medical Commission. So herein we are looking at the data of communicable as well as non-communicable diseases available to the government at a centralized platform of National Medical Commission, hospital management system. Herein the whatever system has been put in place by broad specialty hospitals, this is shared with National Medical Commissions with the help of a application programming interface, wherein this data is available to public health or central government. So this way the data can be shared. But then I will say that primary responders for surveillance purposes, they are not the broad specialty hospitals. So that is one thing. And about the second thing, now as far as this about One Health, role of One Health, and how hospitals look at it from their point of view, or hospital administrators look from their point of view. Taking example of COVID. During COVID, we saw a peak of emergence. COVID was a Mount Everest standing in front of us. And in that, superimposed upon that, were 2 non-communicable diseases: diabetes and hypertension. COVID affected those with these underlying conditions, asthma. One more was asthma or respiratory ailments. But then this somehow gets subjugated. The importance of treating this gets subjugated. Now we dealt with Mount Everest, but then this is yet to be dealt with. The diabetes and hypertension is yet to be dealt with. further on also, whenever some communicable diseases or pandemics, endemics, they come in, these two non-communicable factors are going to affect the health at a larger level. Now, both this diabetes as well as hypertension, they are not problems of undernutrition, they are problems of malnutrition or bad nutrition. Now here, the government has to step in to put in corrective measures at agronomical levels, wherein they have to incentivize production of those food grains or those nutrients, which is going to improve the health. So here we are again looking at the hospitals or data from the hospitals providing an input to agronomical sector to correct its course. Similarly, data from the hospitals, again, COVID was coming in from animal source. So here again, the animal industry or veterinary industry is coming into picture. So one arena of research, one is medical, other is veterinary, third is agronomy. So data has to be seamlessly shared between these arenas so as to work upon the One Health concept or help the people to develop a overall health and environment. Now, the second part that was asked to me was about whether this national programs being part of the hospital setups. Yes, wherever the manpower logistics allow, all those national health programs has to be part of the hospital setups for the simple reason measures were put in place by the government. Are they working or not? So for that purpose, wherever possible, national health programs, they have to be part of the hospital setups, broad specialty hospitals. So that is my response towards the queries that you had put in. Thank you.
Thank you so much for your outlook and also the role of highlighting the role of government in disease management and how really we should focus on that. I would now like to request Dr. Uma Isola to provide her views on the role of health and disease communication in pandemic management and how that led to the development of the Global Learning Collaborative, which is a flagship program of Access Health.
How can I say thank you enough to this audience and to PKC for having me here this afternoon? In a room full of scientists and people who have talked science at different levels in the morning, I was grateful to hear from Soumya ma'am that there is a huge role of communications that actually makes and breaks how we view and respond to pandemics. What we don't realize is it is all about people, and we do know that it is all about people. And people have to respond. They are your main actors. So whether it is normal communication or crisis communication, there are a few channels that will constantly be there and have been there from time immemorial. The print, the electronic media. And what has taken over today is the Snapchat, the Instagram, the Facebook, the LinkedIn, and of course, WhatsApp. WhatsApp University has all the answers to everything that you can think of in different ways, in different formats from different sources, and yet you'd like to believe it. Because your friend sent it to you or somebody sent it to you. So while there is so much they are vying for, if you look at it, the electronic media and the WhatsApp university, if I may call it that, were the ones that stood out in terms when there was pandemic communication and crisis. People screamed, as they always do, breaking news every day. And if you found one more breaking news, you were not so sure whether you believed the breaking news that came 24 hours before that to tell you something different. Some about vaccines, some about masks. And I think in the Indian system, if there was consumption of kadha, as they would call it, putting together many herbs together to think that that was going to wipe away your pandemic. Or, there are so many beliefs, disbeliefs, myths that actually came forward. Who were the main actors that we looked at? Civil societies, community-based organizations, individuals that held positions of importance in the community were the main people that actually infused communication into the people. Vaccine lena chahiye, and you'll find there'll be a queue over there. Vaccine lene se log mar jayenge. You'll find whole villages that abandoned and refused to listen. And you looked at how the COVID monitoring was done through the app, COVID. That was an example of how these communications could actually influence behavior and bring about the engagement of the public. So whether it was digital technology or it was ensuring that people could stand over there and understand that this was going to help and not help. Some sealed off an entire village in terms of communication, and they didn't have COVID for more than a year, not even one. No loved one could come and go. And this was in Telangana. If you looked at it, the major actors were the government, the non-governmental organizations, and also the district authorities that spread the right imaging or the right messaging. So one thing that surely came out was, please, why for attention in communication? People beat themselves over each other to talk about what they wanted to say and communicate it. But what did they do? Did they have strategies to plan that? And that's something that came over time, it didn't happen overnight. So those were the strategies that we can talk about today. One, who should speak? And we started with Dr. Fauci and of course WHO, who actually kept speaking to communicate what the scientists were putting together every day in the evening in their hours of conversation to ensure that we had a safer India and a safer world. It was science-based, it was emotion-based, it was information-based, it was culture-based because different cultures adapted to it differently. And of course, came with that was false and misinformation. So WHO started something called the Mythbusters and constantly put out what are the truths, what should you think of, and what should be the myths. As another strategy we would look at, acknowledge uncertainty because nobody knew whether it was right or wrong. What was true today was not true tomorrow. What was touch and hand washing forever suddenly became airborne. And, how people looked at it and viewed it became different. How do we focus on people's, thought process and literacy? And then we realized that media literacy was people literacy for us. It was not different because media was trying to convey what many people were trying to put together for us to understand. So from the bell ringing to making sure that Amazon left all your parcels on your doorstep, to saying, I'm not going to be in the same room without the air filters that Sir mentioned, people's mindsets have changed. And today, I was a member of the fourth peak. I had it twice. So I know how it felt like. And I said, this is definitely COVID. And nobody was willing to test me. They said, ma'am. So I said, no, I'm going to isolate myself for 5 days. And I'm grateful to see that is this entire room. Please stand up that you are masked, and we should applaud you. Because masking would actually make a difference. And I mean it. We should applaud you for making sure that you still follow what many people do. Yes, I don't know your name, but I'm going to call out to you. Because a lot of people don't understand that the conversation we had about pulmonary and diabetes and hypertension and the long COVID that we have no understanding of can half be prevented by small public health measures like hand washing and masking. So influencing behavior was something that we talked about. Do I have 2 more minutes? Okay. And we have a small checklist of measures that we can look at. And what would they give us? They would test the trust that we can give. We would need to adapt as we went along. And we would constantly have to innovate and monitor to give out the right language and the right messaging. What did we do as a part of this? The Global Learning Collaborative is a learning journey that we created. 100 years ago, we had a pandemic. Last 20 years, we've had several isolated chutput incidents that we have ignored. And finally reached a point where it became the mountain and the Mount Kailash that Sir talked about. But kya hua? What did we do about it? Did we do something about it? So as a part of one of our flagship initiatives, we have instituted something called the Global Learning Collaborative for Health Systems Resilience. And there we have something called the 1+4+3 that we talk about. 1 is people at the center. The 4 are the financial, the governance, the providers, and the supply chain that every pandemic will need to use in terms of rest and when you race. And my boss is a cardiologist. Dr. Krishna Reddy will always say, Uma, the heart can't pump at the same rate when you see a tiger in front of you and you have to run. And COVID was that tiger for us. So we're bringing together learnings from different parts of different areas in all these, from the private, from the public, from individuals, from experts, and pooling that knowledge together to have an overarching effect on the communications. Also, the information, which is the digital era that we are a part of, and the relationships. We wouldn't be in this room to discuss this if it was not for the relationships that we bring together to discuss science and the action. I am also grateful to acknowledge that while I'm in this room, I have a team that works very hard. And we have had people who have invested in our thought, and we have been seed funded by Rockefeller Foundation. We have a whole bunch of experts who give their time. And I stand here on behalf of everybody to say thank you for being present here. Happy to take any more answers and questions as we speak, but happy to collaborate with a lot of people because all this is only possible when we collaborate. Thank you.
Thanks, Uma. The Global Learning Network is indeed a great program, and we appreciate the efforts to build open communication on disease, which going forward, I think is going to be very important. I would like to now call upon Dr. Vidya Mave to kindly give us her views on capacity building and its importance in surveillance. It would also be great if you could talk about the RE-AIM tool that assesses the reach, effectiveness, adaptability, acceptability, implementation, and maintenance of any program, including surveillance program, and specifically reach, the first component of the RE-AIM tool that assesses surveillance program.
Thank you. Thank you for inviting me to be here. So any surveillance program, when we are implementing it, there will be multiple stakeholders, including the healthcare workers, especially for the human side I'm talking about, healthcare workers who are collecting the data. And then there is going to be a cloud infrastructure, which is going to be, coding all of those data or compiling all of those data. And then those data then get analyzed, and the laboratory network, which is also going to be part of that surveillance program. And finally, that data gets analyzed in such a way that is being useful for the local government officials as well as state and national officials. So in this way, when we start a pilot program, the way we did for the PKC for the COVID surveillance program, when we want to expand that program from one couple of hospital settings and to a primary healthcare setup, as well as for potentially for the state level, then this program needs to be evaluated and monitored for various aspects that you just mentioned. First one is that tool, the framework tool is called RE-AIM tool, which is starting with reach. Who is this program reaching? Is surveillance program reaching? Is it only reaching to a local government? Is the end user being the patient population or the community? And then is that going to be any difference with that? And the second part is it effective? How do we know that this program is effective is to say, is it reaching the current population? Plus, is this program leading into a set of directives to the local government officials for the pandemic preparedness? And the third part is the adaptability. Adaptability means you have a system in place already, which is a surveillance program. However, there is healthcare workers who are not really using that system or are not putting in data, which is necessary to make certain infection control measures in the hospital system and or isolation wards or an additional hospital beddings required and all of those being maintained. And also acceptability. Would the program, surveillance program, which is being placed in a district system or sub-district level, would that be acceptable to all the stakeholders? And finally, looking at implementation. Is the implementation starting at a regional level when they get expanded to a state level or a national level? Would there be certain challenges or opportunities which can be gained from that? And then that finally goes into a maintenance stage. A maintenance stage is basically a place wherein there are all kinds of resources are required or implemented for it to be sustainable in a longer term. So that is, I think, one of the framework that is generally used for a program which is in expansion mode. It started at one local level, then it needs to be scaled across the country or across the region. And these frameworks basically involves two different kinds of measurements. One is quantitative measurements, and then is at qualitative aspects. The qualitative aspects, quantitative is straightforward. We are collecting data. Are we seeing a constant flow of data coming into the system? And then it is actually gradually increasing those kind of data set which is coming through. Qualitative is basically a stakeholder assessment, wherein you are looking at either the hospital level or the people who are putting in the data level, laboratory level, as well as local government official level to see whether this program, in-depth interviews are being done, focus group discussions are being done to ensure that this program can be scaled across that region. And what do they think are the barriers? The barriers is that your MIS system, which Dr. Rajendra was talking about earlier, is it user-friendly, or is there any further challenges over there? And then focus group discussion also maybe at the laboratory level. Are they having enough supply chain issues happening, or is enough supplies available so that they can continue doing these testings or not? And so these are part of the capacity building measures where this framework helps for us to expand or scale the surveillance programs. Right now I'm talking about on a human side. Of course, it can also be adapted for veterinarian side, for the One Health context as well. Thank you.
Thank you. We definitely agree and understand the various steps that need to be taken to build a system. I think what's more important is how do you manage it and also understand what the stakeholders are and what they want from it, be it government or private. I would now like to request Dr. Arte to kindly give his thoughts on the center and state mandated disease surveillance program and the intrinsic role that the city administration plays in supporting these programs that are rolled out now at the central level. And how do we work at a city level to build systems that also complement state and central rolled out programs?
Thank you very much. Actually, 21st century witnessed almost 2 pandemics within the period of 2 decades. Or I must say that less than 2 decades almost. And I am fortunate or unfortunate to observe these 2 pandemics as a state surveillance officer of Maharashtra. So these 2 pandemics had changed my perspective as a person, how I look at the society and the disease surveillance per se. Now, just for the discussion purpose, before answering your question directly, I will go to some of the basics of the surveillance, because as Dr. Rajendra and Dr. Vidya, Dr. Uma has expressed different aspects of the surveillance. Basically, surveillance has 5 important components. One is basically collection of data, collation of data, analysis of data, interpretation of data, and then sharing it with the stakeholders to take the appropriate action at the field level. So this is the functional vision of the surveillance. Because when you ask about as a primary respondent to government hospitals, they should have some regular mechanism or system well placed in every hospital, be it a government or private, to do regular collection, collation, interpretation, analysis style of things of their regular data. So that is important. When we think about these different aspects of surveillance, then we come to the importance of basically city-based surveillance, as you asked. So I will go to that. In the morning session, starting from, I think I have heard Gagandeep Kang ma'am and then Sheila Golbole madam. So even I was discussing with Dr. Mahesh from NCL regarding wastewater surveillance. So for technological advance, whatever we have, it is there. The question, because I am a field soldier, so the question for me, the person working in the field, is that how to bridge this gap between academia and the field services. How to translate whatever you are doing at NARI or NIV or at ICMR or NCL to the field level. That is the important question for me. Because we have the technology, we have the capabilities, we have the scientists almost in this one roof, under one roof. There are many people which are distinguished, and actually even beside me, Dr. Misra is sitting here, who was ex-director NIV. So people are there. The thing is that how to translate all this knowledge for practical purpose at the field level. That is the question. And then when we look at whatever has happened, even during influenza H1N1 pandemic or COVID pandemic, the data says that out of the 100 cases, near about 79% cases are from the urban areas. So it actually emphasizes the importance of urban area surveillance. It is not only true about the COVID-19 only, COVID-20, sorry, because Dr. Devakar is sitting in front of me and he knows how dengue is affecting Pune and all those things. So many diseases are, the prevalence of these diseases is much more in urban localities. Because in India, almost all the southern states, including Maharashtra, there is more than 50% urbanization. So every second person is living in the urban space. So without establishing the network of surveillance in these urban areas, you cannot imagine the robust surveillance system in the entire country. So you need to address that. And the challenge is that our urban administration is entirely run by the different department. And then comes the importance of those 3 C's: collaboration, coordination, and communication. So I think Dr. Uma has expressed about the communication, how to collaborate with these different stakeholders while establishing the surveillance network in the urban areas. Sheila ma'am has actually expressed regarding the PM Abhim. So under this Atmanirbhar Bharat scheme, we are actually developing the metropolitan surveillance units in 20 odd cities across the India. And out of that, only 4 are from Maharashtra, including Pune. But in Maharashtra, when we have 35 rural districts, we have 27 municipal corporations. So only 4 cities will not be adequate to develop such kind of things. Naturally, we need to actually replicate or copy paste the things we are doing in Pune, in Parbhani, Latur, and Chandrapur municipal corporations also, because they do require such kind of setup in their areas also. So that is need of the hour. So the another challenge is that whenever we think about the data, because I always say datum is the atom of knowledge. When we think about the data, whenever we need to plan about the city spaces, it is said that the city data or the data pertaining to the urban aspects gets older within 2 years. Whenever you are planning regarding Pune city per se, within 2 years, the data will be old. You need to have the fresh data to plan appropriately. But for rural India, it may go for 5 to 10 years. It will be okay because rural area is not expanding like that. So while planning and developing the structure to keep the pace with urbanization is another challenge. Because when you are planning something under NUHM or PM Abhim, by that time, the urbanization is growing rampantly. There are another cities, and you are just planning for the 4 to 5 cities, and there are another 10 cities coming up, cropping up here and there. So you again fall short. That is why it is need of the hour that we need to understand that we need to be faster. We need to pull up our socks to keep the pace with urbanization. Then and then only it will be helpful. Because there is very good or appropriate dictum from public health. You measure your problem exactly, and the problem is half solved. But due to this lacunae in the surveillance, we are unable to measure our problem exactly, and that is the issue. That is why whatever different people, different stakeholders, development partners, they are actually playing vital role in Bangalore, in Hyderabad, in Pune. With that, we need to develop a uniform urban model of public health. And that need to be replicated at one go across all the cities of India. That will only help. So that is one thing. Another thing is basically, as I have said, we need to think about the One Health aspect, because this basically that has actually changing the perspective of the epidemiology. As we know, for economical purposes, we always say world is flat. So even for epidemiologically also, world is flat. So every disease that is cropping somewhere in the America or Europe or Africa is going to be our future pandemic or epidemic or outbreak. So in that sense, world is flat for epidemiologically also. So when that is happening, we know in One Health, whatever new diseases actually emerging and re-emerging, near about 67% of them are zoonotics. So to come all stakeholders together and sharing of data need to be become quite regular, especially from veterinary and human health and animal health. Every now and there are very anecdotes how this has helped in diagnosing certain outbreaks. Because actually, when we say One Health and when we say the health of human beings, animal, and the environment are actually intermingled and they're interconnected. There is one contradiction whenever we say that. We always think human and animal. We always forget that we are also animal. What happens now, we wear some fancy dress and all those things and sit in the AC room, and we thought that we're not animals, but we are animals. So that is the contradiction in discussing that human and animal health are actually interconnected. Bhaiya, aap animal hi ho. So we need not forget that. That is one thing. So how to go step by step, especially regarding this. So now we have a national program for climate change and human health. And for that, the important component of that is greening of the health facilities or health institutions. Whatever you have, starting from the sub-center to your tertiary care hospital, you need to greening of the institutions. That is one way, because this is a small, tiny step towards dealing with the climate change. Your institutions need to be more climate resilient. And for that, basically energy conservation, water conservation, wastewater management, these are important things along with the green buildings. The building structure should be, they should be eco-friendly, and at the same time reducing the transportation cost. So all these things make your institutions more green, more eco-friendly. So that should be the agenda for at least public health sector. And for that, these are the basically broad principles. How to go with that, that is the important thing. So that is one thing. Another thing is, as Dr. Sheila Madam and Kang Madam also discussed regarding various activities done by the our Apex laboratories. And I have with me Dr. Karyakarte sir, who actually headed the INSACOG of Maharashtra branch and helped a lot during this entire pandemic. Dr. Suvarna Doshi is there sitting over. So what I think basically we should have, because laboratory is the backbone of the entire surveillance system. Please stop me if I'm overstepping the time. Laboratories are the backbone. Without laboratories, without Sheila ma'am and Karyakarte sir and Suvarna madam, we cannot think about the surveillance per se, because you add the quality to the data. So for me, NARI or NIV or any ICMR institution should function as an Apex lab, and they should mentor all the laboratories connected with the medical colleges, because medical colleges have microbiologists and the senior domain expert people with them. So naturally every lab, because as I think Dr. Rakesh was saying, that surveillance is not the job of the laboratories, especially research is their job. Naturally, you need to expand the surveillance, every medical college, because now in India, there are near about 400 medical colleges across India. So naturally, if every medical college is contributing a bit in data collection and surveillance, and if you people sitting over at the Apex laboratories mentor them, that will help in collecting the data across India. That will be more meaningful, that will be more repetitive, and that will also help in actually capacity building of this laboratory. That is one thing. Second thing is that we do have medical colleges, we do have tertiary centers. Unfortunately, we are not aware about the richness of our data that we have at every institutions. Dr. Karyakarte will agree with me. Every medical college need to have a data management and analysis unit, which will be actually manned by the domain experts of statistics, biostatistics, and all those things. Because they have richness of data, they need to evaluate that. That will give something very concrete for our further planning in public health. And that is what data management unit for every medical college is must. And that will also help in planning city level things, because all these medical colleges are actually based in every city. So every medical college is soul of that city. Like for BJ Medical College is soul of the Pune Municipal Corporation. So whatever inputs they will give, they will help Dr. Devkar and his colleagues to implement certain things in Pune. And that is why they should act as a mentor for a particular municipal corporation. And in that way, we need to develop such things. Last thing I will say, and I will stop, that is where also actually think about the policy regarding AMR, antimicrobial resistance. We need to have state level, because we have national level policy regarding that. The state like Kerala has developed state level policy regarding that. We also in Maharashtra especially, and Pune cluster, this knowledge cluster can take this issue, that we need to develop this AMR policy. We need to do surveillance of the prescriptions given by the practitioners, the pattern of use of antibiotics, how they use it, and whether you need to change something with that. Because you need to address the clinical bodies, how the doctors should prescribe antibiotics. And whatever findings our laboratories are giving regarding the resistance and all those things, that should be shared with the clinical bodies, because you need to implement it basically practically while giving prescription to the patients. That is one thing. Second thing, for the animal health purpose, as you know, when we are growing animal as a food purpose, we use antibiotics in a small proportion in these animals. And these things are actually giving rise to the outbreak of AMR. That is the main reason why there is antibiotic resistance. And that is why such kind of use of antibiotics irrationally in animal should be banned, totally banned. Because in certain countries, almost 80% of the consumption of antibiotics is in veterinary population. That was the load of antibiotic use. We need to raise this issue, and as a policy, we should ban such things. Because if you are going to lose every molecule every year or every month, it is very difficult to treat new coming diseases in the coming era. And that is why I think AMR policy is need of the hour. I think, thank you very much. I have taken a lot.
For your insights on surveillance systems and what the gaps are and where we should go from here. Actually, one of the questions that I had for Dr. Mishra was what you mentioned is, Dr. Mishra, if you could highlight the role of research and how we can translate research to a practical, in a practical way, and also look at how we can bring different streams. Like over here, we have various representation from public health. How do we bring it all in together to act upon that kind of data or intelligence?
It's a difficult question you have asked, because there are two ways to look at it. I'm sure my younger colleagues who are very young, they might be very much excited to what we are discussing since morning. They must be thinking a lot of opportunities and a lot of things should be done. Some older people like me, I don't think there are many older than me, but those people may be having some kind of frustration. I have heard it a lot. So many years and decades I heard, and same thing I'm hearing again. So these are different perspectives of different people. I will just take a few minutes to take my journey. See, 1970, I joined as research assistant, and that was first job I had taken. And I joined on a program. That program was Himalayan survey of hematophagous arthropods and serological survey. That was a huge survey work done from Jammu Kashmir to northeastern part. And a lot of efforts were made. 4 years data collection were done. 4 teams were going from Pune to all the way to these places, taking jeeps and all. And I last end of the project, I joined there because my job was to look into the laboratory part of it, identification and serological tools. And I was so excited that I have got such a huge opportunity that this much data, because what was presented to me that it will change the health scenario. Because if we know this, then we will know that what kind of diseases can occur in the country, what can happen in future, what will happen 5 years. Data was collected, huge data, lot of work, lot of people are employed. And after a couple of years, we had some 15 publications, and that is end of it. Nobody even looked at that data. Nobody talked of it, that data, that what it happened, what. So my excitement came down, my God. So much I was excited, but it has come. My bola, anyway, there is something wrong. My seniors have not done good job. So some others, when next time I come, next time things will be better. Coming to, I have been part of the investigation of a disease outbreak or pandemics since definitely I can say thereafter, because my whole career into this. There was JE outbreak in 80s in Kolar area, Karnataka, and we formed a unit which I was heading there. And we were again very much excited that we are going to make a change and we will collect so much data that it will generate a different wave. Whole night mosquito collections we were doing, because not sleeping whole night mosquito collection. Every hour they were separately done. They were dissected. We had huge team of people. They were dissecting age of the mosquito, amount of the blood taken by them, where virus is there, where virus is not there. So I had sleepless nights, and because so much excitement was there. Again, we published 5 papers. And when we gave this data to Karnataka government, they say, why are you creating problem for them? Because they will say that Kolar is only worst place where no action is taken. So please limit your data to give to us. So we said, okay, we will not give data to you, all the data, we'll publish it. We published it again, and matter ends there. Because we had a meeting in, I remember we had a meeting in ICMR headquarters where government representatives from Health Ministry were there. When we tried to present data, what kind of comments we heard was very demoralizing. I will not go in those details. Then in 95, a first so-called outbreak, plague outbreak came into the Gujarat, and I was part of investigating team. I went there. We went again by car, and Gujarat roads were empty. There was not a single soul on the way road to tell us where his guest house is there, because we were supposed to go to guest house. Nobody on the road. Whole city was empty, which in normal course you can't cross the road. We had our own way of getting the people and then doing. We did a lot of rodent collection was done. Blood samples were collected, brought there. PCR was done. Then government says that 2 labs have different results. Delhi lab has different results. Pune lab has different results. Then which one to accept? Then a commission, central commission was formed. Dr. Ganguly was chairman. That time he was in PGI, and he came to NIV, and we gave lot of presentation to him. And then there was a meeting in Delhi. Then they said, I think whole thing is inconclusive, because really nobody wanted to look into the details of it. And subsequently, there were a number of outbreaks, no action was taken. Then 2002 onward, I was director of NIV. I faced number of epidemics. Both I had a global challenge because I was part of WHO teams working on them. First was the H5N1 pandemic, which can kill. That time, what initial data was there, 100% people can be killed. Subsequently, it came still 60% people can be killed with that disease. And influenza, as you know, in 1 month, it can go whole world, around the world. So the amount of panic which was created in the administration was enormous. Because $10 billion US president allotted for that outbreak, and the virus never touched the United States. Right? And then in India, that was the time for us that if I go to ICMR and I say, Dr. Ganguly, I want 10 crores rupees, he was willing to sign a check and give me. Because nobody wanted to take responsibility that mere wajah se kaam ruk gaya. Finally, after that, then all these pandemic preparedness, all these documentation we saw, that was beginning of this, lot of documents were prepared. Every time when new pandemic came in 2007, in between there was chikungunya outbreak, then in 2007 we had H1N1 outbreak. Every time we hear pandemic preparedness document is under preparation. Every time it is prepared, but it is continuously in under preparation. So what is lies, and these data, when they are collected every time, they are very valuable data at that point of time, and lot of effort has been put, lot of excitement of young people who are handling this occurs that time. But where is the problem? You see, today in the context of the what we are doing, zero surveillance, or you say surveys, disease surveillance. Where is the problem? Disease surveillance data, why it is not being used? Because it's very clear. If you can collect data, data is after 3 years, you yourself put in the committee, you will say it is not usable. Because everyone, suddenly more and more people are coming in the field. There is no standardization of the data collection. Somebody has data collected from a particular location, and the whole all 500 samples are collected from one location. Somebody uses a statistical method. So at the end of it, when somebody sits with the data at national level, he feels it is not workable because there is no standardization. In contrast to this, for example, vaccine, you take vaccine preparation or vaccine when it comes into the clinical trial. There is a clinical trial registry. There is a standardized method that to be followed. You have to go to the particular level of standard. We do not have standardization in these things. Everybody gets up, whatever he will call two people, they will prepare a protocol and they will go ahead and implement. So one protocol doesn't match other protocol doesn't match other protocol. In laboratory also, quality is a problem. Suppose a laboratory is not working properly, you get X result. So another laboratory is working properly, you get Y result. Which result you have to believe? The institute which is in higher in ranking, his data is bad, still it has to be believed because other fellows' data will not be believed. He feels frustrated. So there is a need for a lot of standardization, lot of quality to be introduced. Whatever you do, everything is good. Whatever we are talking, everything is required. But where is quality? Nobody talks of the quality. And quality has to be is integrated part of the any surveillance or any laboratory. Not only laboratory, even field. How many samples you are going to take? How your sample size will be decided. Somebody mentioned sample size, we should not waste time. But then one set of data cannot be used with other set of data. So go on creating every time new data, and that new data you give to government. See, I have been sitting in a lot of government bodies for 10 years. At least I was part of the government body to take decision. Government finds also hard to take a decision. It is not that willingly they don't want to do. And for anything, for enthusiasm of the scientists who are working on this, if your data is used, you feel doubly enthusiastic. My data is used. It has, for example, you create a molecule. If it goes in market, you doubly infuse that my data is used and it is of somebody's use. You generate the data, I just publish some paper, and next day onward, nobody looks at the paper. It's such a demoralizing act for the people who work into it that progress will not occur. It is question of demand and supply. See, if you produce something, if there is a buyer, there is somebody to use, then you will produce more and more, you will bring quality control, you will improve your product. But if it is never used, what is incentive for those guys who are producing? Even a farmer will not produce good tomato if tomato is not being sold. So that is in R&D, that is in surveillance, that is a major problem. What is coming? And in Indian R&D, very little fraction is used for anybody, whether it is government, whether it is stakeholder, whether it is by, except publication. I see publication is not, should not be the end objective. Publication is the outcome, probably, but here publication is objective. In university system, if you don't publish 2 papers, you will not be given increment. Your salary may be withheld. But what paper you are publishing, nobody looks. But the same is true in other. Now I'm in university system, so I'm talking university system. Same thing is there. So many universities, now suddenly new education policy has come. New education policy says that every institution, every laboratory should be qualified, they should be regulated, their data should be acceptable. But I bet that even 1% of the data coming from the whole of the universities is worth that it should be used. So there is, what I would try to emphasize, there should be system that data whichever is generated, it will be used, and beforehand, before data is generated, there should be a stakeholder who is going to use it. And we have to keep in mind that what kind of data will be usable to him. Let us not generate data which is for the sake of publication or for the sake that we have generated data to take a pride that Pune generated this data, Bangalore generated this data. For example, my colleagues from Bangalore, PKC, Bangalore Knowledge Center, I was looking at their poster. I said, okay, excellent work you have done. It's very good work they have done. I said that, but this data, where it goes, means how it is, because you are getting data from hospitals, from some clinicians. Is there a quality system to look into that data? He says no. If I say it is garbage and garbage in, garbage out, what it happens, then where it will be used, or whom you are going to give this data? So this question not for them, for us, for everybody is there, that what we are generating, who is going to use, that should be kept in mind first. They should be taken on the board while planning the study, that if data is of this quality and this value, this will be used into this system. And unless that is done, I talked of 50 years, 70 to now it is 53 years. And same story will go on for another half century without making any impact. Any surveillance has not made any impact. What impact made? Somebody made a molecule, somebody made a vaccine that has been taking care of the things. How much surveillance you have used for the control of the disease? Is dengue controlled? Is chikungunya controlled? And don't think data is not there. Tons of the data is there. 15 years back, integrated the national surveillance. We got 500 crores from the World Bank, and the equal amount was given by Government of India. 1,000 crore was spent for the generating quality control data for only vector-borne diseases. What happened to vector-borne? Tell me one city where vector control has succeeded and we have given. So it is lot of wastage of the resources, lot of wastage. So we have to be mindful that who is going to be used. I'm sorry, I have brought tempo little down because that is what has happened to me. So I will say the same to you. So we are also be conscious. Any product you make, think of the user and make accordingly. Thank you very much.
Thank you. Thank you on your emphasis on how we need to standardize data collection and also focus on the end user before designing our work. Dr. Ghosh, I would now like you to sort of focus on the role of foundations in disease surveillance and how they support the government of India, new initiatives that are currently being rolled out by the government in disease surveillance, and also the role organizations play to ensure the success of these programs.
Thank you. So first of all, I really wanted to thank the Pune Knowledge Center from the bottom of my heart for inviting me to this meeting. From the morning, I have been fortunate to hear some wonderful talks, and this has been really, really enriching for me. Thank you. The second, I would really like to place a disclaimer. I think all that had to be said mostly has been already spoken today. There is nothing much that I will be adding to what has been spoken already about. Very enriching conversation. So what I'll do is I'll just do two things, two Bs. One is I'll be brief, and the second is I'll build upon some of the things that have been spoken of. There is a vision that Niti Aayog, with various partners, the Indian Council of Medical Research, various global partners, and also with various domestic partners has built, is the vision document for surveillance for 2030. Most of us have seen that document. Very thankfully, the definition of surveillance has been kept very simple there. It is said that surveillance is information for action. When we started this conversation, I was delighted to hear about the information that will flow into surveillance not coming from various very highly sophisticated institutes like the tertiary institutes and all of that. It really needs to come from the primary level. Think of how wonderful it will be if in the Ayushman Bharat scheme that we have today, the report comes from the PMJ and the primary health centers, and the action is taken at the level of the wellness, health and wellness centers. That will solve much of the problem. But for that, we need data. Data is the information. In today's world, data is an acronym for the surveillance that we are talking about. The acronym stands for digitized, actionable, timely, and accessible information. If we have good quality, digitized, actionable, timely, and accessible information, then much of the problem is solved. The issue then comes to some of the things that we have had as an emerging problem with data during the COVID times, and also in the post-COVID times. You all have read in the news about the data leakage from COVID, how various kinds of trust issues were held. So therefore, coming back to how foundations can work with governments, and when I say foundations, we talk about foundations, partners, and various others, how they can work with government. There's a very simple dictum that needs to be kept in mind by the foundations, by the partners to the government when they deal with data. This dictum is called the PQRS dictum. The P stands for respecting the privacy of the individual from whom the data is being collected. It's very, very important. The Q stands for the quality of the data, being such that it is actionable. The R stands for the reliability of the source of information. We heard about the WhatsApp University. We hear about various other sources with very malintention. Today, communication, as we know, there are two. Earlier in our childhood, we knew about misinformation. Now we hear about disinformation, something that is done with intent. So we really need to focus on the reliability of the source from which the data is coming. And S is the security of the data. Today, data can be used in multiple ways, and the government of India particularly is very, very careful that the data that is collected from her citizens is not misused globally for other purposes. Therefore, the privacy, the quality, the reliability, and the security of the data is a very important dictum that every partner working with the government needs to keep in mind. Now we come to the point about how can we work with the government. We need to think about some examples of how things have happened. The first thing that we can do as foundations and partners is that we can demonstrate some models that can be scaled up by the government. Ultimately, we have to remember that disease surveillance is a public health activity. It is the government which will ultimately own the data, the outcome, the action of a surveillance. But there are various models that we can do. Sir is sitting next to me. In 2004 and 5, when I used to work for Japanese encephalitis program in PATH, I had the opportunity of working with Sir in terms of ensuring that the most impacted places, Gorakhpur, has a laboratory set up with support of NIV, and a surveillance on acute encephalitis syndrome is set up there. That has gone such a long way in ensuring that we have been able to do a very good vaccination program. If we take the example just of acute encephalitis syndrome surveillance for Japanese encephalitis, when we had started the program in 12 districts in India in 2005, from then on, now today, we have moved to hundreds and hundreds of districts throughout the country. This has been possible because there was a surveillance seed that was started in ICMR in partnership with various agencies, the World Health Organization, PATH, and various other organizations in order to do this. The institute laboratories from Bangalore had played a big role into it. NIMHANS had played a great role, Dr. Ravi and others. Now, the second thing that can be done is basically ensuring that there is a good measurement, learning, and evaluation of the program. Various partners, like the Bill and Melinda Gates Foundation, and various global partners, domestic partners, Public Health Foundation of India and others, they have participated with the government to support the evaluation of surveillance programs, and the lessons that have come out have been acted upon by the government. If we take the example of adverse events following immunization surveillance that has been conducted by the Government of India, with great support from John Snow Corporations, from World Health Organization, from PATH, from Bill and Melinda Gates Foundation, there has been a huge improvement in the quality of the surveillance. That's an area that we can work on. The third area that is very, very important when we talk about surveillance, and actually there is no field of public health where communication is not important. There is an issue about crisis communication. It's a form of communication which we apply when, through the surveillance mechanism, we identify outbreaks, and there are panics, there are misinformations, there are disinformations. And in this development of crisis communications, agencies like yours, who is working on communication, partnership to the government, and various other global health strategies, Bill and Melinda Gates Foundation, UNICEF, all of them work with the government in order to build those communication tools. And lastly, I think very important, the laboratory part that we talked about, World Health Organization and various other technical partners. The Johns Hopkins has been a part of it. Harvard is now being a part of it. So there are various institutes that come together to work with the government, and also the government has their own premier institutes, including the leader in the space, which is the Indian Council of Medical Research across the country, one of the finest laboratories that are run. So having said all of this, your second question that was to me was around the different kinds of surveillance that are happening. We have heard of all the different surveillances from the morning, and I have nothing much to add, so I will not continue to ramble on that. But basically, we do understand that there is an One Health approach to surveillance now. It is time, and good time, that we have understood that in spite of us being animals, after all, we label us as humans. We are humans. There are, we are part of the animal ecosystem. But then there is a whole environment. There is a whole issue about the ecosystem of the different vectors, and all of these have to be taken into account. And how the surveillance is now happening is that, as my good friend Dr. Sindhura was talking to the morning, under the larger One Health umbrella of the Principal Scientific Advisor's Office, all of these are coming together. I just want to end by saying a small anecdote. This was told to me by the district collector of Bokaro district in Jharkhand state. So in one of the programs that we were trying to launch then around the acute flaccid paralysis surveillance of polio, we spoke about how to really bring about some good momentum into that surveillance. And I told him that there are so many gaps, how will you address it? He said that the gaps can only be addressed by GAP. So I asked him, so GAP was an acronym that he said. The GAP stands for governance, accountability, and partnerships. In any surveillance that we develop, One Health surveillance or a specific disease surveillance, we will have to take into account governance, making organizations accountable for the role that they play, having very clear terms of reference for them, and ensuring that the entire activity happens under the ecosystem of a larger partnership, which the Principal Scientific Advisor's Office is trying to do in One Health, and of which we are seeing a wonderful demonstration today. Thank you.
Thank you. Thank you for your insights. And I would kindly request Dr. Umesh to talk a little about the role of and the importance of data sharing through COVID, which expedited also vaccine development. And also, what were the lessons that were learned in the implementations of this post-pandemic in reference to data sharing that can progress and push vaccine development?
Yeah, thank you very much. First, my sincere thanks to Priya and Shashi for inviting us over here. So thank you for inviting us. Second, I know I am in between you and lunch, so I'll be seriously brief, actually. So that's that simple. So what we are putting effort is we are really trying to understand and prepare well for pandemic. We have created an infrastructure which is first time in the world, has about 500,000 square feet building, which can deal and produce any technology on the earth, can produce several billion doses in a less than a year's time. So that was our learning curve, because we had to sacrifice a lot during the COVID-19 pandemic. So we build this infrastructure and it's ready. Now you speak of mRNA, you speak of AdVector, you speak of MVA, you speak of any technology, you can translate. So that is the first translation which we have done. It's an infrastructure, and any one of you who would like to visit that, you must visit that. It's one of the finest infrastructure. Nobody in the world has that. The second thing we build is we are really trying to understand the most important thing for whole world is ring fencing a pandemic. So as soon as you get a first incidence, do you have a vaccine ready to vaccinate the people around that incidence actually? And we did this achievement by handling Sudan, Ebola crisis in Sudan in CEPI's 100 days, this one mission. In 60 days, a vaccine got manufactured in serum and it reached Sudan and it got vaccinated all over. So how you ring fence? So for ring fencing, there are 28 agents which will be likelihood of causing the pandemic. And all those technologies we have bought in. We are making the vaccine, storing around 500,000 to million doses in the serum and translating into about few 100,000 doses and actually putting it into several parts of geographies. So as soon as any issue happens, and complete phase 1/2 trial, and as soon as there is any incidence, you at least ring fence, because the cost of lockdowns is so heavy that against that cost of manufacturing this and doing this is really very low. And we are putting these efforts mostly on our own. Obviously now CEPI and others and a lot of other partners are encouraged and they're joining hand with us. The idea over here is, even if we can do a disease burden reduction and disease intensity reduction, that itself is great, because your hospitals cannot get full. And that's the whole idea. And subsequently, we are also putting a lot of efforts in a classical diseases, including AMR very heavily, to how to really come out, because we believe AMR is a pandemic, running pandemic. Nobody's understanding that actually. So we are putting a lot of efforts, understanding a disease ecosystem, right? Put a point of care, easy to use tool for disease surveillance with a track and trace, with a government system, put the data out, and that's what we are putting now. You will see very shortly TB will be, our government of India will be running a big TB program. In that one, we are providing a lot of tools around that. So we are putting these diseases, but you need to understand a lot of ecosystem of each disease is different and the solution around that is different. So you need to put this. So we are putting a lot of efforts around that. So these are the efforts, some of the efforts which we are putting, what we call as a DPT, detect, treat, and prevent. And certainly data sharing is key in all these things. Obviously, what already all the experts have already spoken, that data sharing is easy, no doubt about it, as long as it is done for the surveillance, because it's a national property. But when it comes to IP and IPM, there are certain limitations which comes in. But obviously, as long as it is published and it's made publicly available, the ecosystem will flourish very nicely. That's what is an idea. So beyond that, probably I don't have anything to add, because everybody has already said. And thank you very much. And I hope I'm brief enough.
Thank you so much. I think in the interest of time, if we could just take 1 or 2 questions from the audience, you could just state your name and.
Hello, good afternoon. I am Dr. Yogesh Guru, scientist chef from IISER NIV Pune. I am a group leader of Health Technology Assessment Group in IISER NIV Pune. Since this Pune knowledge clusters population for which they are doing the work is for urban population, in which Pune Municipal Corporation as well as PCMC Municipal Corporations, they have a huge budget, right? That should be used very appropriately for the population of the Pune and PCMC, right? So whatever the important data that need to be generated for the population, if it be shared to the policymakers so that they can take appropriate decisions, a kind of research need to be done. Right. For that, the important thing is that in health technology assessment, the incidence of the disease, which only come from knowing the disease prevalence, and for that cohort studies are needed, because denominator is very important. Whatever the figures we are getting from hospitals, they are very superficial figure, but we don't know the denominator. Second thing is about the costing. What is the cost of that illness for the different health stages of that disease? And third is the utility parameter. So just I want just to ask one question to all the, anyone can inform how this Pune Knowledge Cluster can join hands with each other so that such kind of data would be generated for Pune population for PCMC and for PMC and PCMC. Thank you.
Would somebody like to answer? Shashi, would you like to answer? I think in reference to how we can build these ecosystems, there are a couple of steps that we would take. I think one is building conversations where we can bring enough number of stakeholders to identify areas in which focus has to be taken on from there. I think a lot of what has been discussed today is define how these data sets need to be built, who their end users are, and work on those lines. And also closely work with the government to see what type of data or what type of research do they need for implementation. So I think the way we can work is bringing multiple groups together, identifying focus areas and finding who can address those focus areas and being the go-between to ensure that the work can be done. We can also bring in foundations who have experience in implementation and see what work has already been done. So we don't have to keep reinventing the wheel, and see if a model that already exists can be implemented. I think if anybody else would like to add to it, I think
you did great.
I think there's one more question, and I think post that we can.
Hi, I'm Ravi. I'm an independent researcher. Basically, I'm an ITL consultant turned researcher during the COVID period. I come from a another global any possible global disruptions that could affect an organization. And my experience is also into working for a global organization to change their entire technological landscape so that if a disruption comes in, people have the ability to work from anywhere. So and that way an organization's resilience could continue and the workforce resilience could also maintain its way so that we could balance off things like from a scientific point of view. So from that angle, when I moved into the researching side of what is happening in the global health landscape, what I see, when Sheila Madam, referred to the health intelligence on her slide, that's one of the most critical point of view, because all these discussions that are happening right now is all about silos. What are the issue areas in the silos and what are the strengths and weaknesses which can be addressed in a comprehensive manner. But at the same time, how it's all going to come together, because this G20 presidency is also going to move away to Brazil next year. Before that happens, we need to make sure that, we get something concrete in our thinking so that we don't get to wait until somebody else decides to tell us what we do within our country. But at the same time, when, this pandemic has taught us a lot of lessons, and we have been coordinating a lot of things together for many other countries, and these knowledges could gather up so well, so that we could tell in what way things could happen ahead in time, like capacity building.
Excuse me, do you have a specific question?
Yes, I am. I'm going to give it, right? So the idea is that what I'm trying to put it across is that how are we going to put things together as fast as possible, because AI is coming soon. So we need to make sure that some form of health intelligence structuring should happen as fast as possible. That's what my concern is, really.
I hear you, and I'm going to take that on behalf and in interest of time. Is that okay? Two things.
Yeah.
One, there's a programmatic approach that we have followed for many years. And we have seen some good success in that. You know, smallpox has gone, things are on their way out. There is a learning journey that I talked about.
Yeah.
I think let's join that learning journey. The more the experts that collaborate, the more that knowledge gets built, the more that we are in this room and outside of it, we will be able to keep that knowledge together. And I think I would encourage that we all get into more collaborative mode.
Thank you. In the interest of time, we will have conversations over lunch, but I would like to invite Professor Shashidhara to kindly give a token of our thanks to all the esteemed panelists. I'd like to thank all the panelists for their comments and their time. I'll just hand it over to Priya for a vote of thanks.
Before we break, I would like to acknowledge our partnership and our collaborations with certain government officials who've been very instrumental in integrating the work that PKC has been doing at the government level. We're very thankful to Mr. Suryakant Diokar, Additional Health Officer, PMC. I would request him to come on stage, please. We're very thankful to Dr. Amol Mankar, Consultant, District Health Services. I request you to please come to stage. And also Dr. Rajesh Karyakarte, HOD, Microbiology Department, PJMC. Please, sir. Dr. Raleigh, I request if you can hand over a small token of appreciation for our partners. A brief vote of thanks. I would like to first start by thanking the Office of the PSA for all their support in enabling this event. There will be a report, a formal report prepared at the end of this event, which will be shared with the Office of the PSA for furthering G20 CSAR discussions. I would also like to thank our esteemed speakers and panelists for sharing their views and insights on building disease surveillance systems. I thank our key stakeholders from PMC and PCMC who took the time to participate today despite their busy schedules. A big thank you to the researchers and students who presented posters today. I'm glad that you got an opportunity to showcase your work. The posters will be on in case you are interested in going and viewing them. I thank the Dean of Research, IISER Pune, for enabling us to obtain this venue and all the logistic support that IISER has provided for making this thing happen. Professor Shashidhara, we are very grateful for your support and encouragement, which has made this event possible. So thank you. And last but importantly, I would like to acknowledge my team, the team of Pune Knowledge Cluster, who have worked tirelessly to ensure that this event goes well. Your efforts have made this possible, and a big, big thank you for that. With that, we close this event, and please help yourselves to lunch downstairs in the dining hall below. There is a closed door meeting that is planned, I think about 45 minutes from now, and we have tables reserved for all of those who are attending those meetings. So please use those tables for lunch so that you can have a quick lunch and then move on to your meeting. Thank you.